We are live now.
Shanta ma'am,
Yes,
please switch on your video, ma'am. You are not seen.
yeah. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, AMOGS Emergency Obstetrics Committee with Kalaburagi, Bidar, Bijapur, Raichur, and Basavkalyan Society. So it's my privilege to introduce the convener of today's webinar, Dr. Megha Kamlampur ma'am. Ma'am is the director of Devta Hospital, Kalaburagi, and founder president of Isopar Kalaburagi chapter, and also a member of Foxy Fetal Medicine and Genetics
Okay.
Committee.
It's
I
okay.
welcome you, ma'am.
Thank you. Thank you so much. Namaskar.
It's my privilege to introduce the coordinators of today's webinar, Dr. Krutika ma'am. Ma'am is the fellow in Advanced Obstetrics and Gynecologic Ultrasound at Mediscan, Chennai, 2019, and also fetal medicine consultant at Asha Maternity and Heart Clinic, Bidar. I welcome you, ma'am.
Thank you so much.
It's my honor to introduce Dr. Shanta Durge ma'am. Ma'am is the clinical director and chief consultant at Durge Clinic and Fertility Center, Basavkalyan. I welcome you, ma'am, and I hand over the session to convener and coordinators.
Thank you. Thank you, Saik.
Thank you, Saiti ma'am.
Let us start the webinar with a prayer song.
I think Megha, you can start directly.
Yeah. Thank you, Sahiti. I welcome again all the esteemed speakers, today's speakers, guests, honored guests, and all the faculties, presidents, and secretaries of Bidar, Basavkalyan, Bijapur, Kalaburagi, Raichur districts, and all the delegates today joined for this webinar. It's a privilege and proud for me to introduce our Dr. Sneha Bhuya ma'am, whose CV is so big and encouraging that I have to now make it very precise and small. She has 3 decades of huge experience in the field of women care. Untiring journey with focused approach of Sneha ma'ams has brought many awards for her credit. 2 international awards, 5 national awards, and 3 state awards for professional and academic excellence and her social services. She has 3 awards on her name by ICUG as GCM. And I welcome you, madam, and I hand over this session to you for the introduction of our today's guest, and welcome.
Thank you so much, Megha. In fact, indeed, it's a pride and privilege for me to get associated with the Karnataka societies. A very good evening to one and all, and my respect and regards to all the respected seniors here. At the outset, let me thank respected Dr. M.G. Hiremat sir, the chief patron of Kasuga, who is always there to bless us and guide us. Today, because he is busy, he has just conveyed his apologies. President Kasuga, Dr. Durgadas Asrana, Dr. Shobha Gudi is the Secretary of Kasuga, and of course, Dr. Kiran Kurtakoti, President of AMOGS, Dr. Bipin Pandit, Secretary of AMOGS, and the entire team of Kasuga and AMOGS for helping us for this collaboration. I welcome and thank all of you, dear convener, Dr. Megha Kamlapur, Dr. Shanta, and Dr. Kritika as coordinators. Special thanks to Dr. Seetha, who is the guest of honor, and Dr. Vidya Tobi and Dr. Kasturi Donimath as guest of honor for accepting the invitation. Of course, so regards for all the presidents and secretaries to the five societies, Kalaburagi, Dr. Anubha Hogre, Dr. Meeta Agrawal as secretary, Meeta Harwal, and Dr. Uma Deshmukh and Dr. Savita Badgir for Bidar Society, Dr. Ranganath sir and Dr. Raju Giraddi from the Raichur Society, Dr. Shailaja Bidri, Dr. Manisha from the Bijapur Society, and Dr. Shanta and Dr. Priyanka from the Basavkalyan Societies. So our speakers, I welcome Dr. dear friend Dr. Rajshree Paladi, the President-elect of Kasuga, and of course, Dr. Megha. We have already got introduced to her. I also welcome and thank our expert, Dr. Uma Deshmukh, and the learned panelists, Dr. Sharda Gudage, Dr. Supriya, Dr. Shruti, Dr. Pooja Mise, Dr. Shaileja Talwade, Dr. Priyam Sharma. And with this, I welcome all of you and thank all of you for your gracious presence. I just take this opportunity to introduce our guest for today's program. As sir is not here, we just thank him and for his blessings, and we go ahead with the introduction of Dr. Durgadas, Dr. Kiran Kurtakoti. I hope he joined. He was supposed to join. So I just
Can
introduce.
we have his CV, ma'am?
Yeah. Please project his CV.
Yes.
Dr. Kiran Kurtakoti, he's the president of AMOGS, and he's a very dear friend since last 25, 30 years almost. Very helping hand and a genuine human being. He was also the past committee chairperson of FOXI MTP committee. And of course, I think we will have his words of wisdom little later. Can we have the introduction of Dr. Durgadas Asrana? I mean, it is really, I'm very humble and thankful to you, Dr. Durgadas, for, have this collaboration. And of course, we are very proud to have you as Kasuga president and guest for today's program. He's the past executive member of Kasuga and of course, treasurer as well, past president of Tumkur Society, and I have visited his society also personally. So we are eager to listen to your precious words, and over to you, Dr. Durgadas.
Good evening, one and all. At the outset, I thank Sneha for this opportunity to share the days with all these stalwarts. I'll be very, very brief. Today is a very apt day to talk about beta thalassemia. We have very good speakers like Dr. Rajshree Paladi, Dr. Meghana, and a beautiful panel. I don't want to take much time because so many speakers are there. With these, and I'm very happy to share the platform with Dr. Seetha, with whom I have met after a very long time. Once again, all the best, Sneha, for your future endeavor. We are always with you. Wishing you all the best. Thank you.
Thank you so much. Thank you so much for all your precious words. Thank you so much. Over to you, Megha, for the further proceedings.
Yeah, can I have CV of Dr. Vidya Tobi, ma'am, please? Yeah, Dr. Vidya Tobi, ma'am, had been president of Kasuga 2023. She has long list of awards and accolades on her name, and she is a very good human, a spiritual person, always encouraging for all of us, not only for Karnataka, for all over India. So she has been State Advisory PCP Entity Board Karnataka, chairperson for Food and Drugs and Medical Surgical Equipments Committee, and her committee was awarded as the best committee award by FOXI. Then she is ICUG Governing Council member till 2025. She was FOXI Champion award on her name in 2019. She had been national corresponding editor of Jogi. Then she had been organizing chairperson of Kasuga 2016, and so many awards, madam. We welcome you all. And along with all, I welcome you to this webinar. Ma'am has joined or not, I can't see her.
Thank you.
But,
Yes.
but my respects to you, ma'am.
Yeah.
Please welcome.
Yes.
I have now a CV for Dr. Kasturi, ma'am, please.
Vidya Tobi ma'am has joined.
Yeah,
Yeah,
welcome,
she
Dr.
she
Vidya,
has.
and I'm so thankful
She has
to you
graced the
for
occasion. Thank you, ma'am.
coming
Thank you.
especially from Bangalore.
Yeah, she
Okay.
is there in Bangalore, and despite of her hectic schedule, she has joined for today's webinar.
Let us have few words from you. Yeah.
Can I have now CV of Dr. Kasturi, ma'am, please. As her name suggests, Kasturi.
I think
Though not seen, but her fragrance cannot go unnoticed. Same is true with Kasturi ma'am's work. She has been immediate past president of Kasuga and President Kasuga of in 2022, and she was the professor and HOD in Department of Obstetrics in KIMS, Hubli, a very prestigious institute in Karnataka. She has been ex-president of Hubli Dharwad Obstetric Gynec Society, and she has done a lot of research along with King's College of London, Imperial College of London, John Hopkins University, and WHO as a main resource person. I welcome you, ma'am, for today's webinar.
Thank you, Dr. Megha, for that nice introduction. I really enjoyed it. And thank you for arranging this. And first of all, my special thanks to Dr. Sneha for arranging this webinar and for inviting me. It's a pleasure to be always join the programs done by Sneha. And she's a great academician and a very active member. And also at the same time, I would like to wish her all the best. And I request everyone to support Dr. Sneha and tell your friends also to support Sneha. And all the best for this webinar, Dr. Sneha. And also thank Dr. Durga Das, our president, and Dr. Seetha, who has taken time to join in spite of her busy schedule, and Dr. Kiran Kurtikoti, president of AMOGS, for inviting us for this, and also Vidya, my good friend. Yes.
Vidya madam, a few words of wisdom from you, please.
Very, very good evening to one and all, and thank you, Megha, for those excellent words for me. I thank Dr. Sneha, who is a very excellent academician and very good organizer. For any webinar you take or any workshop you take, she's a very good organizer. I must tell to the audience, whosoever has joined from the Maharashtra as well as Karnataka, Dr. Durga Das has taken over as a Kasoga president, and he is doing excellent work for Kasoga. We too, myself and Kasturi, we are the past president, and we are also joining hands to various activities of Dr. Durga Das. And the committees have come up, and they are also doing very excellent work. Today is a World Thalassemia Day, and aptly Sneha has chosen this day for various topics and talks. And today, I think we should pledge to raise the awareness and stop the disease before it starts. By screening every pregnant woman, we can prevent thalassemia in any future generation. My son is a pediatric hemato-oncologist, and he's a bone marrow transplant also physician. So he gets many thalassemia patients, and always he will be talking to me about thalassemia and all those things. So let us join hands, let us spread the word, and this awareness, let it save lives. I welcome all the stalwarts from AMOGS, as well as I can see Dr. Seetha, who is my very good friend. And I see Dr. Rajshree Paladi, a very good speaker, and so many analysts and my dear friends from Karnataka have joined. I'm also very eager to listen to this very important webinar. All the best, Neha, for your all the endeavors. You have done wonderful work, and definitely you will succeed in this. And I appeal to everyone to help her to nominate as well as to vote. Thank you very much.
Thank you so much, ma'am.
Thank you. Thank you.
Next time we can have your son as a speaker for
Yes,
webinar on thalassemia.
One sec. Dr. Seetha has joined as guest of honor.
Yes.
Let us welcome Dr. Seetha, and let us have a few precious words from her. So all of you know that Dr. Seetha is actually the chairperson, Foxy chairperson for genetics and fetal medicine, and look at those, work and post and position she has hold. So without much, I think spending much time, we are eager to listen to you, Seetha. Over to you.
Thank you, Dr. Sneha. I'm humbled and privileged, I must say that, to share the platform with such stalwarts as the guest of honor. So thank you for giving me this position, which I don't think, But anyway, a big thanks to the AMOGS Emergency Committee, Obstetrics Committee, where with Kiran Kotakoti is the president, and Dr. Bipin Pandit, the secretary, and of course the entire team of KOSOGA, our president, Dr. Durga Das sir, and the secretary, Dr. Shobha Gudi, Vidya Tobi ma'am, who's the vice president-elect, Foxy, and Dr. Kasturi Donimath, who's the past president, and my dear friend Megha, who's been in all our activities, and she's ever been so academic in all her fronts. And I must really congratulate Dr. Sneha for all your webinars. They're really very informative and very academic. So I think this is a very apt day for, thalassemia, because with thalassemia, we know that the theme for this year is Together for Thalassemia, Uniting Communities, Prioritizing Patients. That is the theme, which means that we have to really come together to make these communities aware, because even now about 10,000 children don't survive till the age of 20 years because of thalassemia major. And the amount of money that is spent in transfusions from them, that is a huge load on the family, on the community. So that is what we need to aim by screening, by preventing these. Even one case, if we prevent, I think it goes a long way in, reducing the burden for the family and for the society and for the country as a whole. So a very apt webinar and wonderful speakers you have. So thank you. And I think we should pledge, as everyone said, Dr. Tobi said, that to have a thalassemia-free country. And unfortunately, India is the capital of thalassemia. India tends to be highest in everything. So even this, I think we should have a thalassemia-free country by 2030, apart from our other goals. So thank you, and all the best to Dr. Sneha for your future endeavors. Please support her for the post of Vice President Foxy. Thank you.
Thank you, my dear. Thank you
Thank
so
you.
much.
I will leave because I have to join another webinar.
I know,
So
it's
thank
your
you.
own committee webinar.
Yeah.
No problem.
Thank you, Seetha ma'am. Thank you for
Thank you.
joining.
Thank
Yeah.
you, Seetha.
Thank you, Megha. Thank you so much.
Thank you. I now hand over the session to today's coordinators, Dr. Shanta Durga ma'am and Dr. Kritika.
Yeah. So I just, with God's blessings and the respected seniors' blessings as well, we go ahead with the academic session. And let me just take this opportunity to thank all the respected, dignitaries here, Dr. M.G. Hiramat, Dr. Durgadas Asrana, and Dr. Seetha, Dr. Vidya Tobi, and Dr. Kasturi, and of course our speakers and all the esteemed panelists. I thank all of you, the president and secretaries of all the 5 societies of Karnataka. Thank you so much for, gracing this occasion and blessing all of us. Let us go ahead with the academic session.
Can we have CV of Dr. Shanta Durga ma'am?
It's already projected, Megha. We can go ahead with the introduction of the chairperson.
Yeah.
Okay.
So moving on to the sessions, the first session topic is screening of hemoglobinopathies during pregnancy by Dr. Megha Kamlapurkar ma'am. I would like to introduce the chairpersons, Dr. Shailaja Bidri ma'am and Dr. Annapurna Hogade ma'am. For the detailed introduction, Dr. Shanta Durga ma'am, would you please take over?
Yeah, sure. Today, chairpersons Dr. Shailaja R. Bidri, who is the professor and HOD of Department OBGY at BLD Medical College, Bijapur. And also she is the EC member of KOSOGA, as well as president of Bijapur Obstetric and Gynecological Society. She published so many papers, and she went to as a international and national faculty. She has received many awards. So, and the second chairperson, that is Dr. Annapurna Hogade. She was the past professor at MRMC Medical College. She was there for 25 years, and after that she joined Vikharabad as an honorary professor. She is the examiner for the undergraduate and postgraduate students at various universities. Over to the speaker, please.
Can I share my slides?
Yes, ma'am, you can share the slides, ma'am.
Is it C?
Yes, ma'am.
Megha,
See?
I will put
Yes.
an appeal. 1 second.
This is seen?
One
Yes,
second.
ma'am. Yes, ma'am. We can see.
Okay.
Okay.
So good evening, everyone. And thank you, Dr. Sneha ma'am, for giving me this opportunity to talk on a subject which is very close to my heart. I'm always interested in preventive obstetrics. So coming to screening of hemoglobinopathies, as everybody has mentioned that today is May 8th and World Thalassemia Day. And this year's theme is raising awareness and inspiring hope. So screening of hemoglobinopathies, I will discuss under the headings like why it should be, when it should be. Of course, I limit myself to screening in pregnancy, to whom, of course, pregnant women, and how we should offer it. Coming to why we should do screening of thalassemia or hemoglobinopathies, according to a recent report by the Indian Journal of Hematology and Blood Transfusion, the cost of regular blood transfusion as a vital component of thalassemia management can amount to rupees in 5,000 to 10,000, with patients requiring transfusion every 2 to 4 weeks. So the yearly cost will come as 5 to 7 lakhs. And if this child survives up to 15 years, the cost would come as 75 lakhs to 1 crore. And see the pathetic condition, the amount of the blood transfusion they need, and the sources we have. About 40% of our voluntary blood donation is used for thalassemia patients, and it's a really an economic burden for the family and the nation as well. The good news is that it is still preventable. It's can be prevented 100%, and we as an obstetrician have a major role in this prevention. When we come across the guidelines for prevention for this by NHM, and recently I just saw this thalassemia conclave which occurred in New Delhi on 20th of November 2024, I was surprised that no obstetrician was involved in this, despite of having a major role. So it's very difficult to tackle this situation without involving obstetricians. Why should we bother about thalassemia? Because thalassemia or hemoglobinopathies are the commonest hereditary disorders in India and pose a major health problem. It is the commonest single gene disorder, as we can see here, as the India comes in the red zone here in the world map. An estimated 3 to 4% of Indian population are carrier for beta thalassemia trait, resulting in approximately 30 to 40 million individuals carrying this gene. India has the highest number of children with thalassemia major globally, estimated at about 1 lakh to 1.5 lakh. When we see the Indian map, we can see that thalassemia, particularly beta thalassemia, is prevalent across various parts of India with a higher concentration near eastern and western regions. In South India, Western India, Central India, hemoglobin S accounts to be about 48%. Certain communities such as Sindhis, Kachis, Lohars, Bhanushalis, Punjabis, Agris, Gaud, Saraswats and Gaudas, etc., they have a very high frequency of this thalassemia carrier stain. So hemoglobin carrier frequency for various diseases such as hemoglobin E or maybe hemoglobin S is very high in these states. And when a patient comes from these states, it's our duty to be very cautious for offering them the carrier screening. So what are the clinical manifestations? Because of the abnormal production of the beta globin chain, there can be increased ratio of alpha and beta globin chains, where excess of alpha chains will be there. They will precipitate in RBCs that will lead to hemolysis, causing anemia and all other problems. What is alpha thalassemia? Alpha thalassemia is a state where the alpha globin chains are at the default. So the clinical presentation will depend upon how much severe it is. All the alpha globin chains, if they are at default, then it will be like a HB Bart's hydrops fetalis. This patient or this baby will have non-immune hydrops and this baby will not survive. Whereas if the concentration is less, the globin chain concentration of defective globin chains, if it is less, then the patient can be still asymptomatic, but we need to just have a look on these carrier states. Why there is a rise in the frequency of hemoglobin disorders? It is because of the natural selection, relative resistance of the carrier against Plasmodium falciparum malaria, increase in the incidence of consanguineous marriages in India, the genetic drift which is occurring, and the founder effect all can contribute to the rising trend for this hemoglobin disorders. So when we see this prevention and control of hemoglobinopathies India by the National Health Mission guidelines for hemoglobinopathies in India, we see that there are conditions which are mentioned as these are the conditions which should be investigated, which should be screened. And here we can see that the congenital hypothyroidism, sickle cell anemia, beta thalassemia, they have given it as an optional, which is very, very serious. We need to take care of this. We need to raise an issue that it cannot be optional. It has to be mandatory. And we as an obstetrician or the organization like Foxy can just point out that this cannot be optional. It has to be mandatory for the all pregnant ladies. Coming to hemoglobinopathies, they are the single gene disorders, but they have variable expressivity ranging from mild to severe forms. The identification of carriers is going to allow us to have informed reproductive planning decisions, and that is why we need to screen these patients. So hemoglobinopathies describe multiple disorders that affect the structure or function of the hemoglobin. When there is defective synthesis of the globin chains, that will lead to thalassemia spectrum of disorders, whereas where the hemoglobin itself is defective, then it will lead to sickle cell disease. How is the normal hemoglobin structure? It has 4 polypeptide chains with heme molecule attached, as we all know. So when alpha-alpha chains are mixed with beta chains, then we get HbA, which is a normal hemoglobin. If alpha globin chains, they mix with delta chains, then we get hemoglobin, fetal hemoglobin or hemoglobin F. And alpha chains, when they mix with gamma chains, then we call this as a hemoglobin A2. So the normal incidence of HbA or normal levels should be more than 95, whereas hemoglobin F should be less than 1 in hemoglobin when we do HB electrophoresis or HPLC, high performance liquid chromatography, and the HbA2 level should be between 2 to 3%. These values are very important. Whenever we come across any HB electrophoresis or HPLC report, we should be able to see and interpret them in a very good way. What happens in sickle cell disease? In sickle cell disease, these amino acid sequences which are there, they are replaced. Like glutamine acid will be replaced by thiamine, or thiamine will be replaced by valine. What will happen because of this change? This change in amino acid sequence will cause hemoglobin molecules to get crystallized, where the oxygen levels will come low. And as a result, the red blood cell will stick and get stuck to small blood vessels. The shape of this normal discoid shape of the RBC will become as a sickle cell, which will lead to various vaso-occlusive events that's called as sickle cell crisis. The thing is that thalassemia can coexist with sickle cell disease, and that is the reason the screening is going to help us to pick up these cases. How does the transition from fetal to adult hemoglobin occurs? We know that before 8 weeks, it is the yolk sac which causes the primitive erythropoiesis, and here is the embryonic hemoglobin. After 8 weeks, it is the fetal hemoglobin which starts functioning, which can be seen as alpha-alpha and gamma-gamma, and the fetal hemoglobin falls after birth. After birth, the levels come down, and the levels of the adult hemoglobin slowly start rising, and there is a transition from fetal to adult hemoglobin. So in adult hemoglobin electrophoresis or HPLC, if we see fetal hemoglobin, then it is abnormal. We should not not have fetal hemoglobin in adult patients HB electrophoresis report. So this beta globin gene cluster, the beta globin gene cluster is controlled genetically by chromosome number 11, whereas the alpha globin genes, globin chains will be having genetic control on chromosome number 16. So if there is any disparity, if there is any mutation, this is going to present as various hemoglobinopathies. Various hemoglobinopathies like HbS, hemoglobin type, or HbE, HbD is Punjab, or HbC. All these hemoglobin types we can get on hemoglobin HbLC. So absence of beta globin chains, can it be, it can be complete absence or a reduced rate of beta hemoglobin chain synthesis. These mutations cause defects in transcription or RNA splicing or modification, but that will decide the severity of the phenotype. If there are no beta chains being synthesized at all, then that the spectrum of the disease will be very severe. Whereas if the synthesis of beta chains is less, then that spectrum will be minor, that we call as a carrier or the beta thalassemia minor. So these can be predicted on mutation type, and this is must when we offer them the screening. What happens? The beta chain synthesis, as we see here, it is normal. Alpha and beta are normal, whereas this is reduced beta chain synthesis, or which is called as B plus or B0, where there is no beta cell beta globin chain synthesis. Depending upon that, we can have a healthy patient without mutation or a patient with one mutation where that is a carrier, or a symptomatic patient who is beta thalassemia major patients. So I'll not go into the details of pathophysiology. Only thing is that because there is absence of globin, beta globin chains, there is excess of alpha globin chains, and that will make the RBC very fragile, that will lead to hemolysis, that will lead to anemia and all the complications of anemia. But what happens in minor or trait patients, they are generally asymptomatic. They will have just mild microcytic hemolytic anemia, but we need to suspect them. And when we see such trait patients, it's our duty to have their family history, ask for the family history, ask for the screening of these patients, and then we have to just offer them the definitive screening. We can also suspect beta thalassemia trait or minor if we come across mild to mild trait anemia, which is not responding to our regular treatment. So when we see how the transmission of the thalassemia occurs, we can see here that inheritance pattern outcomes if only one parent is carrier. Here only one parent, this parent is normal, one parent is not abnormal because only one pair of the chromosome has this defective gene of beta thalassemia. So father is a carrier, mother is normal. So what will happen? Their two children will be carriers and two will be normal. So none of them is going to have the disease, but we need to screen them and give them the assurance. What happens in a case where both the parents are carrier? So if mother is carrier, it is our duty to see that if husband is also carrier, because it is going to matter for the transmission of the disease. If both of them they are carriers, then what will happen? One baby will have thalassemia major, a severe disease, or it can be a normal baby which is without any disease or without any mutation, or there can be two carrier children. So 50% will be carriers, 25% chance of having a normal baby and 25% chance of having a baby with beta thalassemia if both of them they are carriers. So this is very, very important. We can have these pictures when we counsel the couple or the family, when we offer them the screening. So along with beta thalassemia, when we screen them for other hemoglobins like hemoglobin S, here also we can see the mother has got carrier G, mother and father, both of them they have carrier, they are carriers for hemoglobin S, and that is why the 50% are carriers, 25% is the disease one, and 25% chance of having a normal baby. But there can be a combination of things. Here, the father is carrier of HbS gene, And here mother is carrier of thalassemia gene. What can happen? Both of the one baby can have both the genes mutation and then can have a very severe disease. Whereas others will be carrier, 50% will be carrier of either beta thalassemia or sickle cell, or one can be a normal child. So all these diagrams are very, very useful when we counsel the couple for screening. But what happens if one patient is thalassemia major? If mother is thalassemia major and father is a carrier, then we can see there is a 50% of risk of having a baby with thalassemia and 50% as carriers. But if both are thalassemia major patients, then 100% all the children are going to have thalassemia major. So this inheritance pattern is very, very important. The same is with alpha thalassemia, as I have discussed. The chromosome 16 defect is going to be at default, and that is going to affect. If it is normal, then nothing will be seen. If the carriers, as I have already told, if all the alpha chains are at fault, it is going to have hydrospitalis, or maybe will not be having a normal life. If few genes are affected, then she is going to be a symptomatic patient. So when can the screening be offered? The screening can be offered as soon as the newborn is there with history, family history. Of course, we have to wait up to 1 year or 6 months for fetal hemoglobin to disappear, and then we should offer them. But ideal time is during adolescence, where most of this, which is very suitable for carrier screening, but it also has got a very socioeconomic background, has to be very educated. People should be motivated to go for adolescent screening. If we miss this chance, there is a chance that we can offer this carrier screening before marriage. But the concern is that if the patient is known to be a carrier, then he or she will feel that who will marry if someone knows that I'm a carrier for this disease. And this is a social stigma that is a major barrier for this premarital screening. If we lose this also chance, then we can offer them pre-conception. But very few times patients come before conception. They will come only once pregnancy test comes positive. With that kit, they will come and seek our advice. The chance we should never miss now is antenatal screening, and we should offer the screening of thalassemia for all pregnant patients. And we have just pledged that we'll be offering the screening to all our patients. How can we offer the baseline screening test? As we know that it is the CBC, or complete blood count. The hemoglobin level will depend upon the severity, whether it is thalassemia major. Of course, the very few patients of thalassemia major will reach the pregnancy state, but it's not uncommon nowadays to have such patients also. We need to look into the hemogram in details, and tomorrow onwards, I'm sure everybody will look for these RBC indices as MCV, MCH, MCHC, which are going to be low. Now, just remember this pair of 75-25. MCV is going to be less than 75 and MCH 25. If you come across this, then this patient should have HB electrophoresis or HPLC. So we can have Menzer index. How it is calculated? MCV divided by total RBC count. So MCV is 75, and if total RBC count is 5, then of course it is going to be 25, which is more than 13. So it is not a case of thalassemia. This is like a screening where we don't have other accesses or if affordability as an issue. So this magic figure, tomorrow onwards, everybody will have. We have to just keep it in our OPD. We have to educate our paramedical staff also, that just go on looking these MCV, MCH indices, and let me know if I forget to see into the hemogram. So abnormal RBCs, of course, everybody will not be getting this type of pictures. We can ask for the peripheral smear and see for the target cells, teardrop cells, elliptocytes, or hypochromatic microcytic anemia, which is again going to help us for the diagnosis. Here we can see this is a case where we have just asked her for the hemogram and then HB electrophoresis, what we routinely do. To our surprise, the hemoglobin A2 level, we can see here it is 6.4. A normal hemoglobin A is 92, and hemoglobin though fetal hemoglobin is less 0.8. So HbA2 here is 6.4. which is more than normal, that is 3.5%. So this was a patient of beta thalassemia trait. Of course, now we need to look into the husband's HPLC, and husband's HPLC was luckily normal. HbA2 is 3.3. HbA is 83.4. So the couple did not need any further investigation or further confirmation. So next off, with naked eye single tube red cell osmotic fragility test is very useful. It can be used at PSC levels at government setups where we don't have any other thing to just screen for these patients. It's simple. It depends upon the principle that the red cells in thalassemia trait are less fragile to hypotonic solution as compared to normal RBCs. So what will happen when we add blood to this distilled water or buffered saline, and if we should take a paper where we draw a black line. So we can see this black line. So the test is negative. If we can't see this black line here in this test, if we can't see this black line behind, then that means this is a positive Nestrov, and we need to go for the further investigations for this beta thal trait. Other tests which can be offered are the CIP test, solubility test, which I will not go into details. But when we screen for hemoglobinopathies, and we are going to concentrate on the hemogram. So once we see MCV, which is less than 80, then our alarms should raise. For less than 80, the positive predictive value here we can say is very low, 37. But negative predictive value is 99%. So if the MCV of a patient is more than 80, there is 99% chance that she doesn't have thalassemia trait. Similar way, if MCH is more than 27%, there is 99% chance that this patient is not going to have thalassemia trait. At least this much we can read from our hemogram. Here I have given these figures as 75, 25 just to remember. So tomorrow onwards, we are going to see MCV and MCH 75-25 pair. I am going to rule out these thalassemia traits in our OPDs. After this MCV, MCH, Menzer index IC, the Menzer index doesn't have any positive predictive value, but still as an exercise, we can see in thalassemia trait, the Menzer index is definitely going to be less than 13 because total RBC count is going to be normal in thalassemia, whereas MCV is going to be less. Whereas in iron deficiency anemia, RBC count is also less, though MCV is going to less. So definitely this Menzer index is going to be more than 13% in iron deficiency anemias. We can have iron studies which will supplement our details. At least serum ferritin we should get. If serum ferritin is low, then we can suspect it is as a iron deficiency anemia, whereas serum ferritin will be normal in thalassemia trait patients with these indices. So after hemogram, it is the HB electrophoresis which plays a role. HB electrophoresis will give us the qualitative diagnosis, but it is the high performance liquid chromatography which will give us the quantitative estimation. Whatever can be quantified, should be quantified, is the rule in medicine. So if HbA2 estimation, if it is more than 3.5%, it is indicative of beta thalassemia trait. So it is very important. And HbA2, if it is still more than 10%, then it indicates HbE. So normal values will be normal hemoglobin. A will be 95% and more. HbA2 should be less than 3 or 3.5, and HbF or fetal hemoglobin should be never more than 2%. So these are the advantages of HPLC and electrophoresis. Main is that the HPLC quantification is possible, whereas in electrophoresis quantification is not possible. So third level of confirmation test, once we are done with the hemogram, second level is HB electrophoresis or HPLC, and third level confirmation test is by DNA analysis of the carrier of the for the detection of the thalassemia gene mutation, which is the mutation which is responsible for this change, because unless we have this DNA analysis in our hand, we cannot offer them invasive testing. So how to read this thalassemia report. Just one more exercise here. You will get this type of graph, and you can see this hemoglobin percentage. Hemoglobin percentage A is here 97%, and HbA2 is 2.5, which is normal. Whereas this type of graph shows hemoglobin A is just 29% here, and hemoglobin F variant is 8.3, which is very high. And HbS here is 59. HbS zone is showing that it is 59. So this is HbS, hemoglobin S. So sickle cell disease. We need to look into such graphs and then come to conclusion. So this is a very small flow chart which has been given by SCOG, where we can see RBC or CB complete blood count, we can see, and then we need to take into the ethnicity of the population and then go for this carrier screening as we have discussed. So coming to one interesting case in our hospital, she is an ex-lady and this baby is A. This mother-in-law, she has brought her daughter-in-law for screening for this baby had a thalassemia major. So she was carrying, and then I offered her amniocentesis. With this amniocentesis, but before that, we investigated this child and the mother and father of this child. They were carriers of this particular gene of beta thalassemia. With this information, we offered her amniocentesis, and the baby in utero was having beta thalassemia minor. They continued the pregnancy. This baby is born. So this is B baby. This is A, this is B, and she is X. Now this hemoglobin, we waited for 1 year, and after 1 year, we got the HB electrophoresis or HPLC of this baby, and this showed that hemoglobin A is 89%, which is still less. HbF variant is 5.3, and HbA2 is 5.7. This means that baby is a carrier of thalassemia, but can have a normal life as like their parents. The story doesn't end here. Then she came with next pregnancy. So third pregnancy, again she was offered amniocentesis, and then amniocentesis again showed that that was a carrier baby. So here again we can see HbA2 4.3, and she delivered a second baby. So now 3 babies. 1A, B, and C. The third baby was also born. This is C baby. But when she came with these 2, she has already lost this A1. So this was a thalassemia major baby. Now she has B and C, these 2 thalassemia traits she has. This lady is mother-in-law. She is very wise. She then brought that ex-patient's brother to me, carrying a baby of thalassemia. It's complicated. So the brother of ex-lady had a child which was detected as thalassemia major. And then we offered them a trio testing, because we cannot do invasive testing unless we have information in our hand. So these 2 are the parents which were the carriers, and this is the baby which was thalassemic. So we did the amniocentesis, and unfortunately, the baby in the womb also had thalassemia major. So they still continued the pregnancy. They wanted that baby, but despite of having this report, they continued. And recently, yesterday we called them up, and then the first baby she has lost, and 1 baby she has with thalassemia major, which they are doing the regular blood transfusion. So the thing here is that we should have a cascade. I really appreciate that lady, which keeps on bringing the patients from her area, her relatives, for screening of thalassemia. Because this is called cascade screening. We need to screen the family members. So when we need the perinatal diagnosis, it is very important that we need to, and one thing important we need to remember is that this testing is not common for all pregnancies. Every pregnancy she has to undergo the test, that we need to counsel them regularly. We need to have molecular studies, identify the pathogen or mutation, and then offer the invasive testing for such patients. So counseling for invasive testing and prenatal diagnosis is what we need is we need to explain them the procedure related risk, what are the benefits and what are the disadvantages of the procedures. We need to offer the maternal cell contamination, which is very important when we do CVS and fetal blood sampling for these patients. Then time taken for the report, we need to have the report before the 24 weeks, which is the timeline for termination of pregnancy. There are still errors because of maternal contamination or technical mixing of samples, and 1 to 2% possibility is there that we need to explain to these patients, and definitely we need to explain about the test failure before we offer this costly invasive test. But there are certain conditions where we need not offer the prenatal diagnosis to these patients, like when the patient has got HBS trait, the lady has got that, and partner is normal. If she has any abnormalities and if the partner is normal, we need not offer the prenatal diagnostic test to them. What are the pitfalls in carrier screening? The normal RBC indices will be seen in carriers with co-inheritance of alpha gene deletion, I mean alpha thalassemias, and beta thalassemia heterozygous mutations. And in these cases, however, the HbA2 will be elevated, and that can give us a clue. Alpha thalassemia carriers will have a microcytic hypochromic picture, but with normal A2 levels. There can be silent HBB carriers with mild beta thalassemia gene mutations, will have normal RBC indices as well as normal borderline A2. Reduced MCV and MCH and normal HbA2 levels can be seen in iron deficiency anemia or alpha thalassemia or other types of hemoglobinopathies. So the importance of family screening, family history is very important, and this is called as cascade screening. Once we come across one patient, may it be thalassemia major or minor, we need to screen for the family as a whole. So what are the prerequisites for the prenatal diagnosis of beta thalassemia? The thalassemia carrier status of the couple should be known. We should identify the mutation before we offer them invasive testing. Once the mutations are identified in the family, the fetal DNA can be investigated for that particular gene or particular mutation. So blood group of the mother to prevent RH incompatibility if we are offering them invasive testing like CVS or amniocentesis, and pre-test counseling with return informed consent of the couple who is undergoing the test is very, very important. So to conclude, prevention is the key to decrease the burden of the thalassemia, and we have the major role for it. We have to screen all women who come to our OPD or a couple. We have to do CBC with HPLC and HbA2 levels. We have to see. Family history is important. Prenatal diagnosis, if both the partners are carriers, for identification of mutation. And we need to explain that this risk is going to be there for each pregnancy and not for one pregnancy. So the choice of couple is very important because they may need to have the children, they may adopt the children, or they can go for in vitro fertilization for prenatal diagnosis, pre-implantation diagnostics testing, which is also a very good option for them. The only thing is monetary constraints. So voluntary genetic testing is important. It has very social stigma, and we need to have a lot of public awareness about this disease. We need to put a little more efforts for the creation of the awareness about thalassemia screening in our society. This is a targeted population screening for carrier status in asymptomatic individuals, stepwise, which is given there in the NHM guidelines. And all patients we are going to screen from tomorrow, especially if they have a particular history of particular ethnicity, MCV is low, or HB abnormal hemoglobin electrophoresis identifies a carrier. We are going to offer them partner carrier screening because fetus will be at risk. We are going to help get the help from a genetic counselor or a fetal medicine specialist. Screen all the family members, offer them cascade screening, and if affordable, we can offer them pre-implantation diagnosis or invasive testing, because preventing the birth of a thalassemia child is the only answer to this worldwide problem to make this world free of thalassemia. And we as an obstetricians have a very vital key role. Thank you. Thank you so much.
Thank you so much, Megha ma'am, for enlightening us so much about thalassemia in pregnancy and all other screening methods. Moving on to the second session, Sneha ma'am, can you go ahead?
No. Can we have the comments from chairpersons? Yeah. Please.
Okay.
That was a very, very elaborate talk on a subject which is very, very complex. And a simple test can reduce the burden on the society as well as the family. And the routine test which we do, if we are alert enough, we can pick up the cases and do the routine checkup and screen them for thalassemia and prevent the burden on the society as well as the family. It was a very, very nice talk. Congratulations. Thank you. And all the best, Neha madam and Shanta madam.
Thank you.
Thank
Thank
you
you.
so much. Thank you so much. I think burden on the country also, as Megha has already
Yeah,
talked about.
definitely, madam.
Thank you. We can go ahead. Yeah. Shanta, Dr. Shanta.
Now the session 1 is over and Dr. Megha Kamlapurkar has given a very good talk, and we'll move to session 2 now, and the topic is management of hemoglobinopathies in pregnancy. So the chairpersons are myself, Dr. Shanta Durge, Ranganath Lingasur. Our speaker is Dr. Rajshree Paladi. So the introduction of the chairpersons, please, Dr. Kritika.
Yes, ma'am. Can we have the slide, please?
Is allowed.
Okay. Dr. Shanta Durge ma'am is the Clinical Director and Chief Consultant at Durge Clinic and Fertility Center, Basavkalyan. She is the nominated member to Karnataka State Supervisory Board PCP NDT. She has received Korean commendation at Siliguri AICOG 1997 for original research work on female feticide. She has also been felicitated with Distinguished Community Service Award at AICOG 2007 Kolkata and Godfrey Phillips Bravery Award at Orissa in 2009.
Kritika, please. Now you introduce Dr. Ranganath Lingasur.
Okay, ma'am. I'll just have one word. Madam is the activist for the Save the Girl Child and Protect Girls' Right movement since past 26 years.
Madam is contesting for Public Awareness Committee of FOXY. So we request all of the delegates who are eligible to vote for her.
Megha, thank you. You really remembered me. And now I appeal to all the presidents and secretaries of the 5 societies which are included in this webinar, as well as our guest of honor, Dr. M.G. Hiremat sir, Dr. Kiran Kurkoti, and Dr. Vidya Tobi, Dr. Kasturi madam, Dr. Rajshree, and all the esteemed faculties. Please nominate and vote for me for the post of chairperson, Public Awareness Committee, FOXY 25. Thank you.
Thank you, ma'am. I would like to introduce Dr. Ranganath sir. Sir is the Chief Consultant and Medical Director at Asare Fertility Center, Lingsur, Raichur. Sir has completed his MBBS from Mysore Medical College and MD OBG from Bengaluru Medical College. He has worked as a consultant in Craft IVF Center, Kerala from the year 2007 to 2010. He has started Asare Fertility Center in Lingsur since 2010 and has offered many obstetrics, gynec, and infertility services with more than 13,000 deliveries. He has started IVF and ICSI Center in 3-tier city, Lingasur, since 2019. Sir has been awarded with Healthcare Excellence Award by AsiaNet Suvarna News Channel in the year 2023 and Basavkalyan Kayaka Award in the year 2023. I would kindly request Ranganath sir to introduce the speaker of the session, Dr. Rajshree Paladi ma'am. Sir is available.
Sir is there?
Yes, ma'am, he's there.
Yes. Please unmute, Dr. Ranganath.
Yes, madam.
Yeah.
Thank you, madam. Thank you for that kind introduction of mine. And I take this opportunity to introduce our President-elect, Kasoga. I'm audible, madam?
Yes.
Yes, sir.
Yes.
I take this opportunity to introduce our President-elect of Kasoga, Dr. Rajshree Paladi. She is a professor of OBGYN in Kajabandhanawaj Institute of Medical Sciences, Kalaburagi, and she is examiner, postgraduate and undergraduate examiner at various universities. She has served as General Secretary, Kasoga, since during 2023 to 25. She was the chairperson of Fetal Medicine and Genetic Committee, Kasoga, from 2021 to 2023. And she is a Dean of Research, KBN University. And she is the director and consultant in OBG in Aditya Multi-Speciality Hospital, Kalaburagi, and she is a gold medalist in OBG. And she is the organizing secretary of 25th Kasoga State Committee Conference, Gulbarga 2014. She is the past president of Gulbarga OBG Society from 2021 to 22. Madam, over to you.
And thank you very much for the kind words of introduction. And also, it's such a great honor, pleasure, and delight to be always associated with Dr. Sneha Bhuyar ma'am. The AMOGS and Kasoga have been hand in hand for many years now, and we are all neighbors and friends. And always, it's amazing to see Dr. Sneha work tirelessly and with so much of dedication and tenacity. When she called me, I just mentioned the same that wow, ma'am, you really are awesome. And that's about the AMOGS and the Kasoga activities. We are all together to share the knowledge and the academic building, which has been going so strong for the past so many years now. And now that Dr. Vidya Tobi ma'am is the president, vice president elect of South, and she's making an untiring effort to join all the South states together. And it's really nice to see that we're all together to share the knowledge, to share the academics, to do good to our patients, and an obstetrician to see that the society and the committees are benefited at large. And this is one such endeavor that we took up hemoglobinopathies on this day. And I was so delighted. I said, Sneha ma'am, thank you, because I'll also go through this topic and revise and learn more. Because every time we accept to talk something, we learn something more. And this is exactly what happened with me also, that we were quite busy for the past 2 days, but then took up this opportunity to share and learn more about hemoglobinopathies. And Dr. Megha has told us what is the impact of hemoglobinopathies now in the country. It takes me back to my internship days in North India, that there was a dedicated ward for thalassemia patients in PGI Chandigarh. I think that is the same in most of the North Indian states, wherein the impact of thalassemia is so very high. And back then, when the availability of blood and the blood supply was so low, so it became very, very important that we cater to such patients with more vigorosity. So this is one such effort that we, can you see me and hear me?
You can. You are audible. Please make this present.
Yeah, well audible. And
am I audible clear?
yes, yes. Yeah.
But you make it
Thank
as a
you so
slide
much.
show.
Yeah. Yeah. So, can you see my slides?
Yeah, but make it slideshow so that it becomes full screen.
Yeah.
Yeah. Click. Your click is on the slide. No, you take it little on at the side. Click it on.
Doing that. Slideshow. Well, just talking about the hemoglobinopathies, we have seen the incidence, the prevalence, and statistics that every year about 30,000 of children are born with thalassemia in the country, and the impact of thalassemia is also quite high and severe. Very well, it has been described about the types of thalassemia and about the various variants. We know that thalassemia and sickle cell disease are the two important components of the hemoglobinopathies, which are mainly due to the globin component, which has been affected. The alpha, beta, gamma, delta are the globins. But when the alpha and beta are majoritarily affected, then we land up in having the hemoglobinopathies in pregnancy.
Sorry to, yeah.
Yes, I'm doing. Yeah.
Yes, yes.
Yeah,
Go ahead, please.
It's now. Yes. Are you seeing my slides, ma'am?
Not yet. Yeah. Now you make it full screen. See what has happened. You have by mistake clicked on the slide. Okay. So that is getting edited. That's why you click at the outside the slide once. You click outside the slide once.
Yeah.
No, not yet. Outside the slide. Just click because that cursor is got stuck there. Yeah. Click on the slideshow.
Yeah.
Yeah, perfect.
Can you see
now? Yeah. I would suggest you to put off your video because I think the network issue.
Yeah. Yeah, it is good, but I will video. Put off the video here in this. Sorry about that. Yeah. Can you hear me now?
Yes. Yes, yes.
Okay. So we know that the hemoglobinopathies is a heterogeneous group of single disorder, which includes the structural hemoglobin variants and the thalassemias. These are inherited specific biochemical disorders with the polypeptide chain of globin fraction being affected. Next. It's okay. So it's common in India, particularly beta thalassemia. The cumulative gene frequency of hemoglobinopathies is estimated that the carrier state could be 2.7 to 14.9 with the mean average incidence of 4.5. And the significant hemoglobinopathies is 1.2 per thousand with the annual birth rate of 32,400 babies with the hemoglobin disorder. So Dr. Megha has told about the structure of the hemoglobin, and we have the polypeptide chains, the alpha, beta, gamma, delta, epsilon, zeta, etc. And the two chains, that is the hemoglobin A, that adult hemoglobin is composed of two beta chains, and the fetal hemoglobin of two gamma chains, and the A2 is two delta chains. But we know that towards the third trimester, the production of the HbF decreases and the production of the beta and the gamma chain increases. So this is how it happens about the from weeks onwards, there is more synthesis of the alpha and beta chains which compose the adult hemoglobin. So hemoglobinopathies are inherited disorders with polypeptide chains of globin fraction. There are two types mainly, wherein the sickle cell disease and the thalassemia. Sickle cell is the structural anomaly and the thalassemia is the defect in the synthesis and production of globin. The sickle cell is an inherited structural abnormality involving primarily the beta chain, and thalassemia inherited defect in the synthesis of production of the globin in otherwise normal HbA. Homozygous, heterozygous, both forms are seen. And we now move on to knowing the sickle cell hemoglobinopathies because extensively it has been described as to how these disorders are caused. Sickle cell disease is the most common inherited condition worldwide, and it's a group of inherited single-gene autosomal recessive disorder caused by the sickle gene, which affects the hemoglobin structure. The sickle cell disease also includes the heterozygous conditions of hemoglobin S, combination with beta thalassemia, and combination with hemoglobin D, E, or O. So genes HbA1 and A2 each code for alpha globulin, whereas only HbB codes for beta globulin. Sickle cell hemoglobin originates from single beta globulin substitution of glutamic acid by valine, and hemoglobin C originates from single beta globulin substitution of glutamic acid by lysine. So hemoglobinopathies that can result in the clinical features of sickle cell include the sickle cell anemia, sickle cell hemoglobin C disease, sickle cell beta thalassemia disease, and sickle cell E disease, which are all associated with high pregnancy morbidity and mortality. Now, HbS comprises 30 to 40% of the total hemoglobin, and patients with sickle cell trait are heterozygous for the sickle cell disease gene mutation and have only one beta chain. So how is the sickle cell trait inherited? If one parent has the sickle cell trait and the other parent has the normal hemoglobin, with each pregnancy, there is a 50% increased chance of having a child with sickle cell trait. If both parents have sickle cell trait, or if one parent has a sickle cell trait and the other has a trait for abnormal hemoglobin, then the possibilities are that in 50% of having a child with sickle cell trait, 25% of having a child with sickle cell trait and without a sickle cell disease, and 25% of chance having a child with the sickle cell disease. Now, because of the sickling, what happens is that there is an increased fragility of the RBCs because the globin chain is affected. The structural abnormalities are occurring in the cell, and whenever there is a tissue hypoxia or there is a microvascular obstruction, there is hemostasis. There is hemolysis as the cells enter into the narrow vascularity. The reticulocytosis can occur, and there could be endothelial adhesions, thereby causing endothelial damage and inflammation, which will now exhibit as acute manifestation because of the vaso-occlusive crisis, acute chest syndrome, liver and splenic sequestration, or infection. Chronically, they may present as a pain or progressive organ damage, which is affected in the brain, lungs, spleen, kidney, heart, etc. Other complications which the patient can present with could be the stroke, pulmonary hypertension, renal dysfunction, retinal disease, leg ulcers, cholelithiasis, and avascular necrosis, which commonly affects the femoral head, and it may necessitate the hip replacement. And the sickle cell disease was previously associated with high mortality rate, but now we know that the children who are born are living up to the reproductive age and have an average life expectancy of at least till mid-50s. So herein comes the role of knowing more about the sickle cell disease, because these are the patients who are getting pregnant. But what happens in pregnancy is that there is increased maternal mortality for the fact that there could be increased venous thromboembolism and thromboembolic events, which could be fatal to the patient and lead to maternal mortality. Other complications like antepartum hemorrhage, infections, perinatal mortality, or premature onset of labor because of the sickling process, fetal growth restriction, acute painful crisis during pregnancy and spontaneous miscarriages, and frequent antenatal hospitalization. So there are fewer reported adverse outcomes with sickle cell disease, but there is an evidence that there is an increased incidence of painful crisis during pregnancy, fetal growth restriction, and antepartum hospital admission and postpartum infection because of sickle cell disease. So to put it in a nutshell, the odds are that there is higher incidence of preeclampsia, preterm birth, stillbirth is significantly high. There could be growth restriction, and it could lead to maternal mortality, which is of great and high concern. One danger, what we may overlook, is that whenever the patient comes with pain, we could overlook it and consider to be either a placental abruption or other intra-abdominal conditions or situations like pyelonephritis and appendicitis. But we have to make sure that we are not missing a serious consideration of sickle cell crisis, wherein the patient can present with a pain. And this is because of the intense sequestration of the sickled erythrocyte and infarction in the various organs, particularly the bone marrow. And these episodes develop acutely, especially in the late pregnancy, or it could be during labor, delivery, or early puerperium. So they have some degree of cardiac dysfunction as well in the patient with sickle cell disease because of the ventricular hypertrophy and chronic hypertension. This further enhances and worsens the dysfunction of the cardia. During pregnancy, the basal hemodynamic state, characterized by high cardiac output and increased blood volume, is augmented. And although most women tolerate the pregnancy without problems, complications such as severe preeclampsia and severe infection can result in ventricular failure. Heart failure can be caused by pulmonary hypertension, and this also must be of consideration. So how do we screen for complications or intensity of the severity of the infection during pregnancy? Once we know that the patient with sickle cell has embarked on the journey of pregnancy, cause for an alert, and this is a high-risk pregnancy, ECG should be performed to rule out the pulmonary hypertension, the blood pressure and urine analysis to be performed to identify the hypertension or proteinuria, renal and liver function tests performed annually to identify the sickle nephropathy and deranged hepatic function. And only when we have ensured these are normal, then the patient can be given a green signal to go ahead with the pregnancy. But yet, even during pregnancy, these have to be mandatorily screened. And retinal screening for proliferative retinopathy, which is common in patients with sickle cell disease, especially with HbA1c, can lead to loss of vision. So sudden loss of vision along with preeclampsia, which can be wrongly diagnosed to be because of eclampsia or retinal detachment, also has to be kept in mind that this could be a sequelae of the disease process itself. Over and above, screening for iron overload has to be done, because in a woman who has received multiple transfusion in the past or who has a high ferritin level, then the cardiac MRI has to be done, which is helpful to assess the body iron loading. And this is significant because whenever the cardiac iron loading is high, there is increased chance of cardiac failure. So aggressive iron chelation should be done before conception, especially who are significantly iron load, and screening for red cell antibodies to indicate that there is an increased risk of hemolytic disease in the newborn. And women and men with sickle cell should screen to know the hemoglobinopathy status and of their partner before they embark on the pregnancy, and at-risk couple as per the National Screening Committee, and they should receive counseling and advice about the reproductive options. So the conditions who require the screening, especially when the mother is diagnosed or known to be affected by sickle cell disease, is that mandatorily to know the carrier state in the partner. This requires referral and counseling to offer the prenatal diagnosis, and also carrier state in the partner, which requires counseling and further investigations, are situations like DB thalassemia, LEPOR, HBE, or hereditary persistence of fetal hemoglobin. So diagnosis, various tests are described, but the commonly used are the sickle cell solubility test, which is the most common. Apart from that, we have the electrophoresis and various tests, that is the persistent reticulocytes, the high fasting serum level, indirect evidence, the cellulose acetate electrophoresis, the isoelectric focusing, and high pressure liquid chromatography can be done. Once the patient is pregnant, it is very important to do the fetal assessment and monitoring of the growth, because they are at increased risk of preterm birth, fetal growth restriction, perinatal mortality, and this should begin from the second trimester itself. That serial fetal growth assessment to be done along with sonography. Although we resort at 30 to 32 weeks routinely, but this has to start from the second trimester itself. And from 32 weeks onwards, weekly antepartum surveillance with biophysical profiles or NST is considered, and transient effects of sickle cell crisis do not compromise the umbilical blood flow, which is a good news. And placenta from the sickle cell pregnancy shows abnormalities when tested. So what additional care should be provided during the antenatal appointment is that they have a high risk for PIH, and therefore BP and monitoring and proteinuria assessed during each visit. And with the pre-existing proteinuria or known renal impairment will require further frequent monitoring, and increased risk of incidence of UTI and asymptomatic bacteriuria, so that urine analysis should be performed at each antenatal visit, and midstream urine should be sent for culture and sensitivity monthly. Now, what is recommended schedule of ultrasound scanning for pregnancy with the sickle cell disease is a viability scan as usual, routine first trimester scan, detailed anomaly scan, and then growth scan for every 4 weeks from 24 weeks of gestation. And since they are at high risk for fetal growth restriction and also the presence of preeclampsia, it allows for the early detection of growth restriction, and hence appropriate time of delivery can be decided to reduce the perinatal morbidity and mortality. What is the role of blood transfusion during pregnancy? Is a prophylactic booster or exchange blood transfusion can be given. The objective of transfusion is to keep the hematocrit value above 25%, the HbA greater than 20%, and concentration of HbS under 50%. The appreciable risk associated with transfusion is this heavily transfused, including alloimmunization, or sometimes the delayed transfusion reaction, which have to be kept in mind, and transmission of infection and iron overload. So the story doesn't end that we give a transfusion. We have to be aware and alert for the overload. A randomized controlled trial and retrospective study have showed that prophylactic transfusion decreases the incidence of maternal painful crisis, but it does not influence the fetal or the maternal outcome. And top-up transfusion indicated as and when there is acute anemia. Acute anemia could be due to the transient red cell hypoplasia or acute splenic sequestration or increased hemolysis and volume expansion encountered in the sickle cell disease. So exchange transfusion can be indicated, especially when there is a stroke. Alloimmunization occurs in about 18 to 36% of the patient, and it is clinically important as it can lead to the delayed hemolytic transfusion reaction or hemolytic disease in the newborn and can make the patients untransfusible. So the most common antibodies which are seen is C, E, and K antigens, and the risk of alloimmunization is significantly reduced by giving the red cells match for C, E, and K antigens. That is, proper cross-matching has to be done. Indications of blood transfusion in pregnancy with sickle cell disease is women with a previous serious medical, obstetric, or fetal complication, those who are on transfusion regimen before the pregnancy, and for prevention of the primary and secondary stroke and prevention of serious disease complication whenever there is a twin pregnancy, because the demand is more, or if there is acute anemia or acute chest syndrome or acute stroke. Because acute anemia acute chest syndrome, there should be exchange transfusion, and women on transfusion prior to pregnancy should continue with the transfusion during delivery. Management of sickle cell disease. Once she gets pregnant, or even she gets pregnant, folic acid, prophylactic antibodies if not contraindicated, iron supplementation, and they should be considered for low dose aspirin 75 milligram once daily from 12 weeks of gestation to reduce the incidence of preeclampsia, and also receive the prophylactic low molecular weight heparin during the antenatal hospital admission, NSAIDs very rarely, and give other modes of analgesia because of the concerns of fetal effects. So infections like pneumococcal infections can be prevented, and it's also advisable to give the vaccination. Penicillin prophylaxis if the patient has had the splenectomy, and hydrourea is used as a disease modifying agent. So what is the optimal management of acute painful crisis during pregnancy? Is the rapid clinical assessment to rule out the other causes of pain abdomen. And if it is severe, oral analgesia. If it is not effective, then give higher opioids like morphine, which is valid in many countries. Give adjuvant non-opioid analgesia like paracetamols, laxatives, antipruritic, antiemetic. All the symptomatic treatment has to be done along with maintaining the vitals and respiratory rate and oxygen saturation 20 to 30 minutes until the pain is controlled and the patient is stable. And rescue doses of analgesia given whenever the pain recurs again. Try to maintain the vitals very well and discharge the patient when the pain is controlled, and improving without analgesia or on a low dose analgesia. Arrange for any necessary home care or outpatient follow-up appointment as and when needed. So what are the other complications of sickle cell and how they are treated? It is associated with other complications like acute coronary syndrome, which is very significant, stroke, and acute anemia, wherein the patient may have symptoms like tachypnea, chest pain, cough, shortness of breath, which is a characteristic feature of acute coronary syndrome. And top of transfusion may be required if hemoglobin is falling, and certainly when the hemoglobin is less than 6.5, it has to be given. And one note is that there is no role for iron, the intravenous iron replacement. So there is an increased risk of pulmonary embolism with the patient with sickle cell. So therapeutic low molecular weight again helps here. And acute stroke, both infarctive and hemorrhagic, is associated with the neurological impairment. And this is an emergency medical care which calls for rapid exchange blood transfusion, which can decrease the long-term neurological complication. And if a stroke is suspected, she should have urgent brain imaging, and hematology should be called for consideration of urgent exchange transfusion. What is the optimum timing? 38 weeks. Do not allow her to go beyond 38 weeks. And the mode of delivery is not indicated by the sickle cell disease. Only the obstetric indications for cesarean section, and it should not itself be considered as a contraindication for attempting the vaginal delivery or vaginal birth after cesarean delivery. And optimal care and place of birth is definitely a high-risk center with the multidisciplinary actions and intensive care unit available, and senior obstetrician and senior anesthetist and multidisciplinary approach should be done. Patient should be kept warm, given adequate fluids during labor, and continuous intrapartum electronic fetal heart rate monitoring is recommended because there is increased chance of fetal distress, increased rate of stillbirth, and placental abrasion because of the compromised placental reserve, which may necessitate the operative delivery. And try to maintain the oxygen saturation above 94, either by giving the oxygen. So they should be offered analgesia anesthetic, and regional or epidural can be given. There is no contraindications to give regional anesthesia. Spinal can be given during cesarean delivery. So what should be the optimum care after delivery is that the fetus, the newborn or the baby also has to be offered for the testing as early. Capillary samples to be sent to the laboratories where there is experience in the routine analysis of sickle cell disease in the newborn. Maintain maternal oxygen saturation above 94 and adequate hydration, and low molecular weight to be administered while she's in hospital, and 7 days post-discharge following vaginal delivery, and for a period of 6 weeks following cesarean delivery. And antithrombotic stockings are recommended in puerperium. The idea or the agenda is to see that she does not have venous thrombosis. And what contraceptive to be given? The progestin is a drug of choice. Barrier is the safe, and other contraceptions like Depo-Provera or Mirena has a grade level recommendation, and there's no restriction for their use, and they are safe to use in the contraceptive methods. Coming to the next important entity, that is the thalassemia, which is one of the common inherited disorders. More than 70,000 births seen worldwide, and the basic defect is that there is a reduced globin chain synthesis. They are classified according to the globin chain affected, and the most common being the alpha and the beta thalassemia. And they represent a wide spectrum of hematological disorders. The red cell being formed are having inadequate hemoglobin content. There is a deficient erythropoiesis, and many different mechanisms are there which explains the prevalence of disease worldwide. So this has been done extensively. I would like to go to alpha thalassemia, which results from the single gene defect of 2 or more copies of the 4 alpha globulin which are prevalent. Deletion of 2 alpha globulin genes causes the alpha thalassemia trait, which could be a mild asymptomatic microcytic anemia. Deletion can be on the same chromosome or other chromosomes. Individuals with these chromosome abnormality are referred to as carriers and are at increased risk for having a child with one or more severe form of thalassemias. And depending upon the number of globin genes which are deleted, the range of the clinical features could be from a normal, unaffected patient to a severe disease like hydrops fetalis. And alpha thalassemia trait is common among the Southeast Asian, African, Western Indian descent. The BART, which is present at birth, is gradually replaced by H, and during pregnancy, anemia deteriorates further. Alpha thalassemia major results in from the absence of alpha globulin, and it's an important cause of non-immune fetal hydrops and perinatal death and intrauterine death and preeclampsia. So all forms of alpha thalassemia can be diagnosed by the NIPT, by the chorion villus sampling or the amniocentesis, as has been described extensively in the screening. And the treatment, the reproductive performance of alpha thalassemia minor is usually normal. They proceed to have a normal pregnancy, and the outcome, they may require oral iron and folate supplementation during pregnancy. And if the hemoglobin is very much low, then definitely blood transfusion and parenteral iron therapy should be never given. So beta thalassemia is two genetic loci for beta globin chain synthesis exist, one on each of the chromosome 11. Mutations of the beta globulin genes result in either complete absence or impaired production of beta genes. In either case, there is a relative excess of alpha chains, and excess alpha chains bind to the RBC membranes and cause membrane damage. So classification of beta thalassemia based on the description of the molecular mutation or by the clinical manifestations. Individuals who are heterozygous for this mutation have beta thalassemia minor, and those who are homozygous have beta thalassemia major, that is a Cooley's anemia, or a milder form is called the thalassemia intermedia. Beta thalassemia major, characterized by severe anemia with a resultant of extramedullary erythropoiesis, delayed sexual development, and poor growth. Beta thalassemia minor, the proportion of hemoglobin A2 is increased, and depending upon the amount of beta chain production, it is usually associated with asymptomatic and can often occur in HBS. In the most severe form, no normal beta globulin chains are produced, and this results in a clinically severe syndrome called sickle cell beta thalassemia, in which no HbA is produced. Beta thalassemia major is when both the beta globin alleles bear the mutation, the beta globulin chain synthesis is severely restricted, hypochromic microcytic anemia results, which starts from few months after birth and will require lifelong transfusion. And this is what is very, very challenging and high impact for the family. The fetus is unaffected, though, because HbF has no beta chains, and elevated levels of HbF in individuals with beta thalassemia major partially compensate for the absence of Hb. However, death usually occurs by the age of 10 years unless treatment is begun early with periodic blood transfusion. And when transfusion, severe anemia is reversed and extramedullary erythropoiesis is suppressed. So what is the beta thalassemia trait? That is the intermediate in homozygotes with less severe beta thalassemia mutation, often referred to as beta thalassemia intermediate, is defined as a group of patients with thalassemia whose disease severity varies, and the severe end of the spectrum is that undiagnosed patient or between the age of 2 and 6, or they can survive without like regular blood transfusion, and the growth and development is impaired. So any child presenting such should be evaluated for thalassemia. So at the other end of the spectrum is asymptomatic until adulthood and only diagnosed at chance. And diagnosis is dependent on patient maintaining a satisfactory hemoglobin level without requiring the blood transfusion. So additional risk to the woman and baby during pregnancy, cardiomyopathy to the mother during iron overload, increased risk of fetal growth restriction like in sickle cell, and around 9 months of little or no chelation, women with thalassemia major may develop new endocrinopathies like diabetes, in particular hypothyroidism and hypoparathyroidism due to the increased iron burden. So what is the optimum preconceptual care for the women with thalassemia? Each visit, the thalassemia team should discuss the documentation and intentions regarding the pregnancy, explaining them the full range of the spectrum of what complications they can anticipate, and specialist hemoglobinopathy center advised. And nowadays we do have specialists who deal with such hemoglobinopathies, and women should be advised to use contraception despite the reduced fertility associated with thalassemia before as an interpregnancy interval. Fertility is reduced because of transfusion-dependent individuals where chelation has suboptimal and iron overload occurs, resulting in the damage to the anterior pituitary, but they may require ovulation induction using injectable gonadotrophins to conceive. There is no contraindication for hormonal methods of contraception. Interventions which are of use at the preconception stage is aggressive chelation in the preconception to reduce and optimize the iron burden and reduce the end-organ damage. Due to lack of safety data, all chelation therapy should be regarded as potentially teratogenic in the first trimester. Desferoxamine is the only chelation agent with a body of evidence for use in the second and the third trimester, and the optimization of the iron burden is critical for the ongoing iron accumulation from transfusion in the absence of chelation and may expose the pregnant patient to high risk of new complications related to iron overload, particularly diabetes and cardiomyopathy. So, diabetes mellitus is commonly seen in adult patients with thalassemia. And although diabetes is multifactorial, but then its association is well demarcated, HbA1c is not a reliable marker for glycemic control, as this is diluted by the transfused blood and results in underestimation. So, serum fructosamine is preferred for monitoring of the glycemic index in diabetic patients with thalassemia. And women with established diabetes mellitus should ideally have a fructosamine concentration of less than 300 nanomoles per liter for at least 3 months prior to conception. And this is equivalent to HbA1c of 43 millimoles per molecule. So this is a significant consideration to keep in mind that fructosamine concentrations are useful in monitoring the patient. Hypothyroidism is also frequent in patients with thalassemia, and untreated hypothyroidism can result in maternal morbidity and severe perinatal morbidity and mortality. Now, significance is that the woman should be assessed by a cardiologist with expertise in thalassemia and or iron overload prior to going on to the pregnancy. ECG and should be performed, and also the cardiac MRI, because the iron load of the cardia is very significant. So also the liver iron concentration should be scanned by using the Feriscan or the liver T2 MRI, and liver iron should be less than 7 milligram per gram. So liver and gallbladder and spleen, if present, ultrasound should be done to detect the colitis and evidence of liver cirrhosis due to iron overload or transfusion-related viral hepatitis. And cholelithiasis is common in women with thalassemia due to the underlying hemolytic anemia, and they may develop cholecystitis during pregnancy. Liver cirrhosis and active HCV may run a more complex clinical course during pregnancy in patients with thalassemia, and women who are having HCV RNA positive should review by their hepatologist preconceptionally. Now, because these women have received multiple blood transfusions, they all have to be screened for various viral loads, etc. And bone density scan, osteoporosis is a common finding, and women should be offered a bone density scan to document the pre-existing osteoporosis. Vitamin D concentration optimized with supplements if necessary. The pathology is complex, but it is due to varied factors like the underlying thalassemic bone disease or the chelation of calcium by the chelating drugs or hypogonadism and vitamin D deficiency. Red cell antibodies, ABO, and food blood group genotypes and antibody titers should be measured. The alloimmunity can occur in 16.5% of individuals with thalassemia, and the RBCs indicate a risk of hemolytic disease in fetus and newborn. And if antibodies are present, there may be a challenge to obtaining the suitable blood for transfusion, and it would be of confusing effects. What medications should the patient receive? Is iron chelators should be reviewed, and desferoxamine and defiperidone ideally discontinued 3 months before the conception. Desferoxamine has a short half-life and is safe for infusion during ovulation induction therapy and should be avoided in the first trimester owing to the lack of safety, but can be used after 20 weeks of gestation. What's the importance of genetic screening and what procedures are done for the woman with thalassemia is that if a partner is carrier for hemoglobinopathy, it may adversely affect the woman's genotype, and genetic counseling is offered. And pre-implantation genetic implantation should be diagnosis should be considered in the presence of hemoglobinopathies in both partners, so that a homozygous or a compound heterogeneous pregnancy can be avoided. If there's sperm donors considered, because if the partner is affected, then definitely there is an increased chance of thalassemia. And this happened to one of my patients, very high profile and very well to do and well placed, is that when the first child was affected, severely affected, and then they went in for pre-implantation genetic diagnosis before they continued with the second pregnancy, which turned out to be positive. So in today's era, wherein even tier 2 cities have the comfort and the luxury of offering the pre-implantation genetic diagnosis and the IVF protocols, I think these should be used extensively. And this is one of the very important clinical situations when the application can be used. So conditions requiring counseling where the mother is affected by thalassemia is beta thalassemia, HBS, HBE, delta thalassemia, HB leopard, HBO Arab, or the variants of the hemoglobin, HBC, and other variants. The risk is mild to moderate disorder in HBC and other variant hemoglobins, whereas it is serious. Risk is serious in all the hemoglobinopathies like beta thalassemia and HBS. So immunization and antibiotic prophylaxis carries a very important role. Hepatitis B vaccination is recommended in HBS AG negative women who are transfused or maybe transfused. So also the hepatitis C, and women who have undergone splenectomy should take penicillin prophylaxis or other antibiotics, and all women who have undergone a splenectomy should be vaccinated for pneumococcus and Haemophilus influenza type B if this has not been done before. Vitamin supplements as and when needed, and folic acid 5 milligram 3 months prior to the conception. And woman who has got pregnant has to be reviewed like the routine ANC protocols for monthly until the 26 weeks and thereby fortnightly. And women with both beta thalassemia and diabetes should have the monthly assessment of the serum fructosamine concentration and review with the specialist diabetic clinic and not the HbA1c. And all women with thalassemia major should undergo specialist cardiac assessment at 28 weeks of gestation mandatorily, and thereafter as and when felt needed or appropriate, thyroid function test should be monitored, and all women with thalassemia major should receive blood transfusion on a regular basis to keep the hemoglobin level at 10 grams per liter. So the transfusion regimen has to be managed during pregnancy with thalassemia intermedia as well, and antenatal thromboprophylaxis. This is of great significance and role both in sickle cell disease and in thrombophilia. And women with thalassemia who have undergone the hysterectomy, splenectomy should have a platelet count greater than 60,000 and should continue or commence taking the low dose aspirin 75 milligram per day. And with women who have undergone splenectomy and a platelet count should be also offered with the low dose heparin, that is a low molecular weight heparin prophylaxis. And those who have not taken low molecular weight heparin should ask to continue or start during the antenatal hospital admission. Women with myocardial iron, this is a new learning which I came across, is that the iron loading should, when done, they should undergo the regular cardiology review with careful monitoring of the ejection fraction of the cardia, because this is the first indicator that there could be cardiac decompensation and there could be complications for the pregnancy. So that cardiac MRI should be undertaken who have not received preconceptional assessment and there is a concern about the cardiac function. And women with liver iron and the hepatic loading should be carefully reviewed and consideration given to low dose desferoxamine iron chelation from 20 weeks of gestation. Intrapartum care, timing of delivery as per protocol, senior team members available, and in the presence of red cell antibodies, blood should be cross-matched for delivery since it may delay in the availability of the blood. With thalassemia major, intravenous desferoxamine 2 grams given over 24 hours should be administered for the duration of the labor, and continuous intrapartum electronic fetal monitoring to be continued. Thalassemia in itself is not an indication for cesarean, and active management of the third stage of labor and cesarean delivery as and when indicated. Postpartum, since there is a high risk for venous thromboembolism, the prophylaxis to be continued. Breastfeeding is safe and has to be encouraged. And due to the presence of abnormal red cells in the circulation, low molecular weight heparin prophylaxis while she's in the hospital, and also to be continued 7 days post discharge following the vaginal delivery and 6 weeks following the cesarean delivery. Women with thalassemia major who plan to breastfeed should restart the desferoxamine as soon as the initial 24 hours of after delivery, and since it is secreted in breast milk but not orally absorbed, therefore it is not harmful to the newborn. There is a minimum safety data on other chelators, so desferoxamine continues to remain the drug of choice, and pregnancies in women who have thalassemia is very few recorded. Audit should be carried out approximately every 3 years, and this should include preconceptional compliance with targets for liver iron, cardiac iron, and fructosamine, thalassemia, intermediate pregnancy outcomes, especially indications for transfusion management of maternal anemia in non-transfused patients with fetal growth restriction, and compliance with prophylaxis against venous thromboembolic disease in women who have undergone splenectomy. So this have been taken from Green Top Guidelines, the ACOG Practice Bulletin, Williams Obstetrics, and Aries Practice. guideline. Thank you all for the patient hearing.
Thank you so much, ma'am, for the incredibly informative and engaging presentation. Can we have comments from the chairpersons, please?
Hello. Dr. Rajshree Paladi. Can you hear me?
Yes.
Can you hear me?
Yes, madam. Yes,
Dr. Rajshree Paladi has given a very extensive and elaborative talk on hemoglobinopathies, one of the most difficult to understand for the normal obesity. These thalassemia and sickle cell diseases, they are considered as high-risk pregnancies, and it involves high suspicion for the diagnosis and investigations directed for the same. As that nowadays there are most of the labs are doing all these investigations, and so diagnosis has become easy. But the only thing is we have to have a suspicion of these hemoglobinopathies. This requires multidisciplinary action as well as a special care at antenatally, intrapartum, and postnatal, and also the contraception. So delivery should be at the intensive care units with the intensive neonatal care. The newborn should be screened for the same. And one important thing is what Dr. Rajshree Paladi has stressed, that these hemoglobinopathic patients, pregnant patients, where diabetes is there, so our routine HbA1c is not of value, and the glycemic condition has to be monitored by serum fructosamine. So the very detailed talk on hemoglobinopathies. So thank you, Dr. Rajshree Paladi, for your very excellent talk.
Thank you so much, Dr. Seetha. Thank you, Sneha ma'am, and wish you all the very best. So also, dear Shanta, we hope to see you both there on the talk.
Thank you so much, Claire. Thank you. That was excellent. That was excellent. I have already written in the comment box also. Thank you so much.
Thank you.
And 1 minute, Dr. Sneha Voyar, our beloved Dr. Sneha, who is very hardworking, and I think we all should support her to her this vice president endeavor of Foxy. And even please support me also. Thank you. Thank you.
Thank you so much. Thank you, Dr. Shanta.
Thank you, ma'am. Moving on to the next session, which is a panel discussion on hematological problems in pregnancy. The moderator for the session is Dr. Sneha Bhuyar, ma'am, who is AMOGS Chairperson, Emergency Obstetric Committee. As Megha ma'am has already introduced her, shall I move ahead, ma'am? I would like to invite the expert for the session, Dr. Uma Deshmukh, madam. Madam is the HOD of Obstetrics and Gynec Department, RIMS, Bidar. She is advanced.
Morning, I woke up, I saw tired.
Hello.
Yes, Dr. Krutika, go ahead.
Okay, ma'am. Can we have the slide, please? Yeah. So, Dr. Uma Deshmukh, madam, was the advisory committee member of PCPNDT Bidar district from the year 1996 to 2020. She is also the nodal officer for maternal mortality from Bidar district from 2000 to current. She was involved in training of trainees for SBA, CAC, and PPIUCD and EMSCH in collaboration with Singapore team. She's an instructor for Jiva Raksha ECLS training for medical students. She has received the Best Doctor Award from Endanger NGO Bengaluru in the year 2019. Received the Sarvottam Seva Prashasti from the government of Karnataka on 26 Jan 2020. Received Stree Shakti Prashasti 2020 from Sharana Basaveshwara University, Kalaburagi. Received the award Aspiring Women Award in the year 2021 from Vega NGO Bidar. And she has received multiple appreciation certificates from different societies. And she has also received appreciation certificate from IMA Bidar. I would heartily invite you, ma'am.
Thank you, Krutika. Thank you.
Next, I would like to invite the panelists for the session. First panelist is Dr. Sharda Gudge, ma'am, who is the director of Gudge Hospital, Bidar. Madam is also a fellow in ART and fellow in hysterolaparoscopy. Her field of expertise are infertility and ART, hysteroscopy, laparoscopy, colposcopy, embryology, and high-risk obstetrics. She has established the first IVF center in Bidar, delivered the first ART baby in Bidar, specialized in high-risk pregnancy management, and attended various national and international conferences in the field of ART and gynecology. Welcome, madam.
Thank you.
Our next panelist is Dr. Supriya Tile, ma'am, who has completed her MD from AIMS, New Delhi. She's a fellow in reproductive medicine, medical director and fertility consultant at Lotus Hospital, Kalaburagi. Associate Professor at ESIC Medical College, Kalaburagi. Her fields of interest are reproductive medicine and high-risk obstetrics. She was a treasurer in Gulbarga Obstetrics and Gynec Society from the year 24 to 25 and also joint secretary from the year 23 to 24. She was the executive committee member of Reproductive Endocrine Committee, Kasoga, from the year 23 to 24. She has won multiple prizes in paper presentation in different conferences and has 20 publications in both national as well as international journals. Thank you so much for joining us today, ma'am. Our next panelist is Dr. Shruti Marguti, who is an obstetrician and gynecologist from Kalaburagi. She has completed her researchship in MRMC Kalaburagi and is FOXY trained on basic ultrasound under Dr. Megha Kamlapurkar, ma'am. Welcome, Dr. Shruti. Our next panelist is Dr. Shailaja Talwade, madam. Madam is the director of Talwade Group of Hospitals, consultant obstetrician and gynecologist in Talwade Hospital, Bhalki from the past 23 years. And she has been conducting more than 22,000 plus deliveries single-handedly, for which she has received Achievers of North Karnataka Award in the year 2024. She has completed her fellowship in cervical cancer and colposcopy under Dr. Priya Ganesh Kumar, on-site fetal medicine training under Dr. Pratima Radhakrishnan, and has been trained under Dr. Vivek Krishnan Sir for fetal neurosonography. She is the only female member of Rotary Club Bhalki, and she has conducted many awareness programs on cervical cancer and breastfeeding. She is a faculty at various regional and state conferences. Welcome, madam. Our last panelist for today's session is Dr. Priyam Sharma, madam, who is a consultant obstetrician and gynecologist at Sagar Maternity Hospital, Kalaburagi. She is also an infertility specialist and gynec endoscopy surgeon. She has completed her MBBS at prestigious Mahatma Gandhi Memorial Medical College, passed DNB from Chinmay Mission Hospital, Bangalore. She worked as an assistant professor at Vaidehi Medical College, Bangalore, and also Gulbarga Government Hospital, Kalaburagi. She is a member of various societies, and she has represented Gulbarga Obstetrics and Gynec Society at Yuva Foxy as a chair speaker in the year 2018. She has presented paper on laparoscopy in AICOG 2019 Bangalore. Welcome, Priyam ma'am. I would like to hand over to Dr. Sneha ma'am to continue.
One more panelist
is joining. Okay, I am sorry, I was unaware of that.
I think Dr. Sharda Gudage, Dr. Supriya Tile, Dr. Shruti, Dr. Pooja Mise, Dr. Shailaja Talwade, and Dr. Priyam Sharma.
Yes, ma'am. I've introduced all the panelists.
Yeah. So thank you so much, Dr. Kritika, for that introduction, and thank you for the coordination. You really worked hard for this program. So thank you so much. So friends, without much, it's already too late, and without much ado, we go ahead with the panel discussion. The common hematological problems during pregnancy which we obstetricians are facing is anemia. The incidence is more than 50%, pancytopenia, hemoglobinopathies, thrombocytopenia, and thrombophilia. So you have heard about the hemoglobinopathies, but anemia being, so rampant, the incidence being more than 50%, all of us must know what exactly should be the hemoglobin level. And this is what the theoretical aspect, but I would just say at no point of time it should go below 10.5. That is what is the requirement. But according to WHO, hemoglobin percentage of less than 11 gram percent is, labeled as anemia during first and third trimester. But second trimester less than 10.5 gram percent, and postpartum also less than 10 gram percent. So, all of you know all this theoretical aspect that there is volume expansion by 50% and the RBC mass increases only by 30%, and that is why there is relative erythrocyte dilution or hemodilution. So we will not go into all these theoretical aspects. I will just ask Dr. Sharda Gudage that why there is a normal physiological hemodilution, which I have just said one sentence about this, but why there is iron deficiency during pregnancy?
During pregnancy, there is increased maternal plasma volume by 40 to 50%, but RBC volume only by the 20 to 30%. That result in a disproportionate increase in plasma and RBC volume, and that leads to hemodilution, and that leads to simultaneously hematocrit value fall down, and that's leads to the iron deficiency anemia in a pregnancy.
Yeah, but that is hemodilution of pregnancy. What we are talking is usually majority of the women, they have iron deficiency anemia. So why there is iron deficiency? What is the requirement and what is the supplementation or supply?
Ma'am, in pregnancy, there is a 30 milligram per day iron requirement of pregnant lady, and non-pregnant lady only the 18 milligram per day requirement, and the hematocrit value of the fall down, and that's why the iron deficiency will happen in a pregnant woman because of the hemodilution.
Yes, so the total iron requirement during pregnancy is 1000 milligram. Fetus and placenta almost 300 milligram, and the RBC mass actually 500 milligram, and the basal loss is 200 milligram. So totally actually you require 1000 milligram of extra iron, and that is why there is relative iron deficiency. So I would just ask all of you, does this severe anemia appear all of a sudden, or it has certain stages where you can diagnose much earlier, even before the hemoglobin level comes down or the patient becomes symptomatic?
Ma'am, there is no severe anemia sudden will happen. That how we can diagnose with all the full hematological investigations, like we'll do the hemoglobin level, we'll do the RBCs, we'll do the packed cell volume, hematocrit value, MCV, MCH, MC and HC, serum iron levels, total iron binding capacity level, saturation level, and the serum ferritin level. According to these all levels, we can divide our anemia in the 3 stages: first stage, second stage, and third stage, ma'am.
Right.
And according to the first stage, we have to see in the first stage there is a iron store depleted and the liver and the spleen will not get complicated or not targeted organs. But in the second stage, there is the ferritin level.
The bone marrow is the major storage, right? Bone marrow.
Bone marrow.
And liver and spleen. You're right. Okay. So, but bone marrow.
Bone marrow is hampered in the third stage of the anemia, ma'am.
No. See, it's a depletion of the iron stores first. So iron stores are where basically liver, spleen, and bone marrow. And when you do the bone marrow picture, you can diagnose anemia much before. So depletion of the iron stores is the first stage, and second stage is.
Second stage.
Yes, I think next panelists can take up. No worries. You can now. We can hand over. Dr. Priyam, you can take up. Anybody else? All of you, all the panelists, please, unmute yourself.
Ma'am, stage second is the stage where it is deficient in the erythropoiesis, where the RBC production is deficient. So here at this stage, we can see that the RBC indices starts to fall. So we can detect anemia at this stage when we can do the RBC indices and see that there is fall in the MCV, MC, HC, and the RBC indices. And the third stage is where the clinical symptoms, signs, and full-blown iron deficiency anemia is established.
Yeah,
so it is not a not one-time disease. It's a progressive disease where we can even detect it early also.
Yeah, so what the scientific evidence says that initially there is depletion of iron stores, that is in bone marrow, liver, and spleen, and second stage, and that this will take months together to manifest as frank anemia. Second stage is falling ferritin levels, and third stage is fall in the hemoglobin levels. Okay, so Dr. Supriya, should we screen all women for anemia during pregnancy, and what's the best time to screen for anemia to avoid complications?
Ma'am, I would like to say that though we are now in the era of excess, where we are seeing that obesity is becoming the pandemic because of our faulty dietary habits, it is very unfortunate that we still keep on discussing iron deficiency anemia and anemia due to other nutritional deficiencies. And with the highest prevalence of 50 to 60% in India, with the recent survey showing that it has highest prevalence of 50 to 60%, definitely all the pregnant women should be screened for anemia during the pregnancy.
Perfect. What is the ideal time?
So the best time would be at the first antenatal visit when they come for the first antenatal visit. And then again after that, when the physiological changes of anemia are at the highest at 28 weeks, and then at term would be the best time to do the HB testing.
So Government of India recommends that hemoglobin estimation should be done at least once in a trimester. So first antenatal visit, then 16 to 20, 24 to 28, and 34 to 36. Okay, so this is how it should be. So even ACOG, American College, recommends that yes, definitely the women must be screened for anemia during pregnancy, because for them the incidence is less, so it may not be so frequently, but for us it is a must. So Dr. Shruti, why are we worried so much about the anemia during pregnancy? How do they affect each other?
Yes, ma'am.
Let's hear from you.
Complications of anemia and pregnancy, like antepartum, there will be a complications like increased risk of preterm labor and premature rupture of membrane, preeclampsia, IUD, antepartum hemorrhage, cardiac heart failure, and intrapartum complications will be like
This one. Yeah.
prolonged
This
labor,
one.
fetal distress, abruption, postpartum complications like puerperal sepsis, PPH, lactation failure, and subinvolution of uterus, postpartum depression, and fetal outcome will be having low birth weight and prematurity infections and neonatal anemia. And pregnancy on anemia will be having like anemia will be further aggravated onset of the pregnancy, and body will demand will be increased, and there will be essential
worsening of the situation. Yeah.
for the fetus will be provided increased, and increased metabolism and enhancement of maternal circulating blood value, and there is a sluggish digestion, and postpartum blood loss will be there, that will aggregate maternal anemia, and lactation is the further maternal resources to further.
So all in all, it will worsen the anemia, and of course, the patient may land up into congestive cardiac failure as well. Okay. So these are all the factors already. The effect of pregnancy on anemia and anemia on pregnancy you have discussed very well. So let us go to the case discussion. So Dr. Pooja Misre, we have this patient for you. Third gravida para 2. She already had stool living issue. Still, she has 3 months, amenorrhea, and she wants to continue this pregnancy. So she comes to you with, weakness, easy fatigability, breathlessness. There's no complaints of pain or bleeding PV when you examine. The vitals are stable, but per abdomen also there is no significant finding, soft, non-tender. Only report she carries is hemoglobin of 5 gram per cent. I'm sure you get this patient coming to you from villages. So what is your clinical diagnosis, and what other investigations you want to come to definite diagnosis and go ahead with the management?
Madam, she's a gravida 3 para 2 live 2 and amenorrhea of 3 months.
Yes.
Normally, when we the presentation what she's presenting is more towards an anemia, and diagnosis, if I want to come just by a clinical diagnosis, and she's carrying only a report of HB which tells around 5 gram, it is a severe anemia. But our principle of management tells it should be based on the severity, based on the amenorrhea, that is the gestation, period of gestation, and then what is the cause of anemia. These things will follow the principles of management. So I would like to evaluate her further.
What investigations first?
Yes, I would like to evaluate her from the basic investigations like CBC and complete hemogram, hematocrit, reticulocyte count, peripheral smear for the type of the morphology, cell morphology, any anisocytosis or poikilocytosis, and
any other information the peripheral smear gives you?
Yes, ma'am. Like if there are some many fragmented cells or anisocytosis or poikilocytosis, it goes for the another form of the anemias. And I would like to go for the RBC indices, ma'am, like MCV, MCH, MCHC, and RDWs.
Yes.
Then comes the serum iron levels. That is, it can be a serum ferritin, PIBC, percentage saturations. Based on that, we can come to the diagnosis. Like, for example, if I take an HB as a percentage.
So whether it is an iron deficiency anemia or no? Yes, perfect.
Yes, for example, if it is a RBC indices I am following, MCV is less. So more towards it can be an iron deficiency anemia, or it can be more towards an thalassemias and all those things, hemoglobinopathies.
And
but
that
if
is why
MCV
you
is
go for
not.
serum ferritin levels and iron.
Yes, madam. Yes, madam. And if the MCV is in the higher range, then I may think more towards a folate deficiency and the vitamin B12 deficiencies.
Okay. What else? What other investigations?
Even the stool examinations for any parasitic infestations.
Occult blood.
Yes, occult blood.
Bacteria. Yes.
Yes, ma'am.
Okay. What else?
Based on this diagnosis, If it is a severe anemia, more towards an or anything, the management will be a severe anemia. It's a blood transfusion.
Okay.
Based on the condition, we have said she's a stable condition, not having any other mean vitals are stable.
She's
Yes,
symptomatic.
she's symptomatic. Okay, if she is symptomatic, symptomatic management has to be started with blood transfusion being the thing. And once we have investigated her these things, we'll be able to come to the cause of the diagnosis. And cause-wise management can be done.
So yes, so that is wonderful, Dr. Pooja. We go ahead with Dr. Shailaja. Dr. Shailaja Talwadi. Do we have Dr. Shailaja here?
Yes, ma'am, I'm here.
Yeah, yes. So, madam, what kind of, suppose, this patient, you have given a blood transfusion, but that will be only symptomatic, for initial few days, but you have to stimulate her own erythropoiesis. So you want to, maybe simultaneously you get the report that yes, it's a iron deficiency anemia. So she's having first trimester pregnancy and, lots of nausea, vomiting. So you decide for injectable iron. Which iron you will prefer, and how do you calculate the dosage?
Ma'am, injectable iron, actually it is not indicated in first trimester, of course. And there are three generations of...
Madam, just let me clarify. It was around 5 years back. It was said that injectable iron is not recommended, but it has been proven beyond doubt that the FCM is safe during pregnancy, even during first trimester. That is documentation. Okay, so let us come to the conclusion that yes, you can use FCM and even the I3 nowadays. Okay.
Yes,
how to calculate the dosage?
Okay, ma'am. Before that, there are three generations of injectable iron, madam. The first generation of injectable iron is that the one we used to use earlier, that is Jectofer.
Yeah.
And nowadays it is not used, ma'am. The second generation. Yes, ma'am. The second generation of iron is the iron sucrose one, ma'am. This iron sucrose is the one we use nowadays. It is commonly used, and it comes in the vial of 100 milligrams, 5 ml vial. And that is most commonly used now. And the third generation one is that FCM, which is very best, but it is very costly. And now that we know that there are three generations, how do we calculate when we are telling them? Then there is a formula for the calculation of the need of iron. That is 2.4 into, that is iron deficit. That if 11 is the normal HB, and what is the patient HB? If we minus, then we'll get that value into 5 plus 1000 milligrams extra for the extra need. So this is how we calculate.
Into pregnancy weight in kg.
Pre-pregnancy weight.
Pre-pregnancy weight in kg. Yeah.
Yes, pre-pregnancy weight. And this iron sucrose is usually given in 100 ml NS, madam. Not iron sucrose, sorry, madam. Orofor SR iron sucrose is given in 100 ml NS within 15 to 20 minutes, and 2 vials are added, and it should be given alternate day.
FCM, actually you require, most of the times it is only single dose. 1 gram you give, it is usually a single dose. And what are the adverse effects of any injectable iron, that is IV iron we are using nowadays? So what are the side effects, madam? And why? Which preparations have lesser side effects?
Hypophosphatemia. Hypophosphatemia is the commonest side effect with our FCM.
Okay.
And anaphylactic reactions.
In fact, it is the adverse reactions. Immediately the patient may get nausea, vomiting, maybe some rash all over body, and body ache, severe body ache or fever, like they usually get it, joint pain, etc. But anaphylactic reactions have also been noticed. Okay, so though we have, I have also seen initial days I have faced, but there are certain preparations with which we have already faced some reactions. So the logic behind this is actually they say that of course the quality control, but the molecule which has got a very low molecular weight is safe to use. That is what is the explanation scientifically. Okay. So thank you so much, Dr. Shailaja. That was a very nice explanation, discussion from your side. Let us go ahead with the second case. Dr. Priyam Sharma, this is a case for you. We have this 23-year-old pregnant lady with 28 weeks of pregnancy. and since last few days, maybe 4 weeks, she's experiencing petechiae, bleeding gums, epistaxis, and that started during the second trimester of this pregnancy. When you examine, you find the vitals are otherwise okay, only the pulse rate is little high, 112. There's no fever, bruises, splenomegaly, lymph node enlargement. How will you, investigate and manage this patient? What will be your approach?
Ma'am, this patient is 28 weeks pregnant. She's telling that she's having fatigue. And on examination, there's pallor that suggests that patient is having anemia. Along with that, she is giving a history of petechiae, gum bleeding, and epistaxis. That shows there is some problem in the bleeding time. That shows that there can be thrombocytopenia associated with anemia. So it can be either nutritional cause, or it can be the maturation defect or the proliferative defect.
So we investigated her. I'll just give you the investigation reports that the platelets are, only 15,000. Okay. The hemoglobin is 5.4 gram percent. MCV is 90, MCH is 33, MCH is 32, WBC is 4,200. Okay. So with an absolute neutrophil count, that is also low. Okay. So what is your diagnosis?
Ma'am, there is all the three lineages are lower in count and quite low. Like platelets are very low. Yeah, and hemoglobin is also suggesting a severe anemia. And red cell indices are showing a normocytic normochromic picture. Along with low WBC
coagulation profile was normal and Coombs test was negative. Okay, even because the other viral markers also were done, that is negative. Fanconi anemia screening was also negative because she was investigated by a hematologist naturally. So bone marrow aspiration showed hypocellular marrow. So what is your diagnosis?
Ma'am, since Coombs test is negative, that shows there's no autoimmune hemolytic anemias, and viral markers are negative, so the infective causes like hepatitis B, parvovirus, Epstein parvovirus is ruled out. Fanconi's anemia is negative, that shows that no inherited causes like is involved in this patient. And bone marrow aspiration is showing a hypocellular marrow. Hypocellular marrow shows that it can go to aplasia, where all the three lineages we will see very less count. And ma'am, there is no abnormal cells or dysplasia that rules out leukemias and lymphomas.
Right.
If there is no granuloma, that shows that the other disorders like tuberculosis, sarcoidosis is ruled out. And this trilineage hematopoiesis is suppressed. That shows, ma'am, it is going more over for the aplastic anemia, ma'am.
Right, aplastic or a hypoplastic anemia. Okay. So how do you go ahead? Clinically, suppose whether you have splenomegaly or no splenomegaly, will your approach differ?
Yeah, ma'am. Yes, ma'am.
How?
Yes, ma'am. If the patient is having pancytopenia along with splenomegaly, we have to go for bone marrow aspiration. And bone marrow aspiration, if it is showing any abnormal
You have
cells.
to go for whether you have splenomegaly or no splenomegaly. Yeah, for pancyto, you have to go for bone marrow aspiration, right?
Yes, ma'am.
Yeah,
Yes, ma'am.
that is what I want to give the message.
Yeah.
That
Yes, ma'am. Depending upon whether it is splenomegaly and so depending upon the splenomegaly, whether it is present or not, our diagnosis can go, ma'am. In case of if there's no splenomegaly and bone marrow is showing hypocellular or acellular picture, that goes more towards aplasia, which can be ruled out whether it can be acquired cause or it can be inherited cause. Or if there is bone marrow picture is abnormal with no splenomegaly, we have to go for leukemias, lymphomas, ma'am.
Right. And of course, as I said, hypocellular, you may have, a mild sort of, just or a hypoplastic anemia. Hypoplastic bone marrow sometimes, so that is how.
Yes.
So if the bone marrow aspiration, suppose you do, and if that is normal, then what is your conclusion? The cells.
If bone marrow, yes, ma'am, then it can be a splenic cause hypersplenism can
Right.
cause that can cause the destruction of the blood cells inside the spleen, or
Right.
if there is a portal hypertension, whether it is pre-hepatic or hepatic, that can
Yeah.
also cause the destruction of the RBCs that
Right.
can also be associated with splenomegaly.
Yeah.
And
So,
yes, ma'am.
so our clinical diagnosis is hypoplastic or aplastic anemia. So, Dr. Sharda, what is your diagnosis now? How would you go ahead with the management? Suppose you have this pancytopenia with aplastic anemia.
Ma'am,
That is your diagnosis. How would
yeah.
you go ahead with management?
Ma'am, this is plastic anemia. In this, the 3 cells are depressed and no palpable spleen, and the bone marrow is hypocellular. That is the aplastic anemia only.
Yes.
And there is no abnormal infiltration in the bone marrow fibrosis also.
Right. Right.
And the management is the patient is
with the hematologist.
Hematologist, yeah, ma'am. Hematologist.
Yeah. But because she's our patient, we need to know something about this, because aplastic anemia is actually known to cause lots and lots of antenatal complications, especially the spontaneous abortions, preterm labor, and even IUD, right? And so this can be the leading cause of death even of that pregnant woman, because so many complications, antenatal, intrapartum, and postpartum also. So that is why we have to be really worried about this. So we go ahead with the treatment options. Dr. Supriya, can we have the treatment options from your side, if
Yes,
at all?
ma'am. Since it is a case of aplastic anemia, the treatment approach should be a multidisciplinary in liaison with the hematologist, anesthetist, and the neonatologist. So as an obstetrician, and depending upon the cause, if it is a reversible cause caused due to infections or because of the drugs, that can be stopped, or the infection can be treated, and thus the aplastic anemia can be treated. If it is not due to a reversible cause, then comes the main approach. Here, the main concerns will be, one is the anemia, where in case of aplastic anemia, the hemoglobin can fall up to 2 to 3 gram% also. And the next issue is of that of the thrombocytopenia, where the platelet levels go down, and there is a risk of life-threatening hemorrhages. The other concern is that of the neutropenia, leading the patient for repeated infections and also sometimes life-threatening infections also. So the definitive treatment
for
of
her, the hemoglobin is 5. So you would like to go ahead with blood transfusion, right?
Yes.
Yeah. And
if the hemoglobin is less than 5, suppose if the patient, it also depends upon the symptomatic profile of the patient and also the associated comorbidities, because we have to again outweigh the risk of multiple transfusions causing hemochromatosis, that is iron overload, and also the risk of alloimmunization.
How do we combat that iron overload?
So we can start the patient on desferrioxamine, which is an iron chelating agent. Or if the patient is not symptomatic and if the patient is not having bleeding, then we can avoid giving blood transfusions also, and treat the patient on oral hematinics like that. And the next would be the definitive treatment of aplastic anemia includes mainly the immunosuppressive therapy with cyclosporins, anti-thymocyte globulin, or stem cell therapy, which are ideal choices for non-obstetric patients. However, these are not well studied and not proven to be effective in the obstetric patient.
Yeah, if you remember that her history, when we taken her history and we examined her, she had petechiae, right? And she has a bleeding tendency also, epistaxis, etc. So anything special for that? That aspect also we have to consider, right?
Since the patient is having bleeding and her platelets are low, so we can transfuse platelets for her, either a single donor plasma, that is SDP, or we can go for a RDP also.
Plasma, yeah. Okay. So, and also we have to avoid pricks and cuts, and even
yes, we have to avoid any kind of intramuscular injections to the patient. So again, which will lead to the risk of bleeding and bruising and hair.
Yeah. Have you ever managed such patient?
Aplastic anemia, maybe during my post-graduation, ma'am. After that, I have not seen any cases of aplastic anemia.
Any drug being used that time?
That time, as an obstetrician, we were only concerned with the supportive care, that is correction of anemia, thrombocytopenia. And then for the further definitive management, we would refer the patient for a hematologist, where they would start on immunosuppressive agents like cyclosporin.
Cyclosporin. So that was a time when it was only cyclosporin, but now you have this Eltrompo bag. Eltrompo bag, you know. So this is a nowadays these hematologists are using, and that is, you know, that actually binds to the thrombopoietin receptors, and that is how it improves, you know, the platelet production, overcoming the depletion of the hemopoietic stem cells. Okay, so it's like competitive inhibition. So that is how it binds to the receptor. So how do you follow? You give cyclosporin 150 milligram twice a day. Of course, it's a cytotoxic drug. Folic acid 5 milligram once a day we give. And this is romiplastin 250 microgram subcut, that is to be given every weekly. And then of course the routine iron and calcium. And blood and platelet, as you have already said, and you have to monitor the mother as well as the fetus for their well-being. Right. Okay. So now this is actually a case shared to me by one of our friends, you know, from Patna. What she has faced, whether you agree to it or no, you please let us know, because we are here together to discuss. So this actually at 34 weeks, you know, breech presentation, she comes to her already in labor pains, and you know, when she examines, the os is 3 to 4 centimeter dilated, cervix 2 centimeter long, breech at -3. And there is a septum felt, anteroposterior septum, vaginal septum. Okay. Her counts, these are the investigation reports. RBC was quite good that time, 2.9 lakhs. HB was 7.8, platelet only 28,000, and leukocyte 6.1. Okay, 6,100. So how do you manage these cases? How she has managed, let me tell you. We'll just see, and what is gone wrong, whether you agree to it or no. You know, the assisted breech vaginal delivery. And then the section, the vaginal septum excision was done. Okay, this was in a medical college. So mild traumatic PPH, vaginal repair was done, and you know, packing was done. 2 packed RBCs for the random donor platelets were transfused. Baby was 1.9 kg, cried after birth. Everything, you know, the patient, she landed up into the stairs also, she landed up into PPH also, and they have to resect also the vaginal septum. So with such bad reports, and the breech at -2, -3 and 2 centimeter, whether in your practice do you go for breech vaginal delivery like this in this patient, or what you would have done for this patient? That's a question for all the panelists.
Ma'am, will not go for the normal vaginal delivery. Suppose this patient is almost 2 centimeter and 3 to 4 centimeter dilated. She is in active labor. We have to transfuse the blood simultaneously, and we'll go for the cesarean.
Not even in active labor, if you go by WHO definitions, more than 6 centimeters should be active labor, and the cervical length is 2 centimeters, right? Not even effaced well. Correct?
Ma'am, we can go for first the complete blood transfusion with the single donor ma'am, and we'll wait for we'll wait for
what I'm trying to ask you, or giving whether you agree to this management, whether in practice you will do like this. Yes, Madam Shailaja.
Ma'am, actually, they were scared about low platelets and this thing, and so they must have not taken her for section. But with platelet transfusion, I think we should have, because primary breech itself is an indication.
That too, when it is not, you know, breech on perineum. Yeah, it's long time, because
in spite of knowing all this, looking at the blood pictures, they must have waited. And actually, in my case, if I was there, I would have gone for a section under GA, and with the platelet transfusion less than 20, it is told, ma'am. If platelet is less than 20,
28,000. Now she has 28,000.
28,000.
Yeah, if it is less than 20, definitely you wait for platelet transfusion. But even if it is 28,000, I would say yes, arrange for platelets. Because why I'm saying, first and foremost, she's priming. Secondly, it's a breach. Thirdly, she's got a vaginal septum. And you don't know how the labor is going to progress, okay? If at all she lands up into severe traumatic or atonic PPH, because of this prolonged labor and lots of, interventions as well, because it will be an assisted breech delivery, okay? So in this situation, she has a worse chance of having PPH, right? Traumatic as well as atonic. So I think making arrangement for lots of blood and blood components, especially platelets, we should have taken her for cesarean section. So this was just for discussion, because they were in medical college having, everything around. So they tried and they succeeded. So I just thought of sharing this and, taking your opinion. How do you practice in your practice? Okay. How you would have done it for your practice. So I think that should be all. And Dr. Pooja, now we go ahead with this next case. Primary gravida, 7 months. I think we will have this as a last case. It's quite late nowadays. Now, so primary gravida with 7 months amenorrhea, she comes to you with, severe body ache, upper abdominal pain, swelling of lower extremities, breathlessness, and high colored urine. So when you examine, you find that she's got severe pallor as well as icterus. So what is your clinical diagnosis and how would you investigate and go ahead with the management?
Madam, by the history itself, there is a complaint of pain with anemia, and the another findings what I've got is an icterus. So this all is more towards an hemolysis, hemolytic anemia. And as is the most common causes of hemolytic anemias now, they are like sickle cell anemia or the thalassemias. Then others are like acute blood loss, I mean other things. But if we take the further, when we see there are like on examination and on investigations, I think there are fragmented RBCs seen there.
Yeah.
So which will go more towards a sickle cell anemia, complaint of pain with anemia, with the hemolytic features, with the investigations, it is more towards sickle cell anemia, but still I need to evaluate with other investigations also.
Like?
Further, it is like we may specific investigation.
For sickle cell anemia, what investigation you want to go for? For confirmation. We are not saying screening. Screening is sickling test, okay?
Yes, ma'am.
Okay. So
the sickling has already been. So it is like hemoglobin electrophoresis can be done, ma'am.
Hemoglobin electrophoresis or HPLC, whatever is available, right? So definitely that gives you a confirmation of the diagnosis. Now, for this patient, yes, she was having hemoglobin, YFS. And so actually what should have been, if this lady is having SS,
so the chances
talk about retrospection later on. Her liver function test, bilirubin and LDH were high. Renal function tests were okay, but for fetus also we have done everything. Now you tell me that what is this condition she has presented to you?
She is already having SS. So the chance of sickling, the chance of affected child will be around 50%.
No. What does the patient present to you now? This, severe body ache, joint pain, abdominal pain.
She's already in a crisis, madam.
So this is actually the vaso-occlusive crisis.
Vaso-occlusive crisis. Sometimes involving the organ damage, sequestrations of the organs and all. So typical presentation of a crisis because of the sickling of the cells.
Yeah. So if she's assessed already, the child has 50% of chance having the SS, right? And both husband and wife are carrier. Even then, they have 25% the carrier as well as sufferer, and only 50% will be normal. That is how. So any lady who presents to you with some hemoglobinopathy, it should have been actually a premarital counseling and testing, but if not, at least preconception, and even if not that, so during conception, early pregnancy at least, CVS, Korean villus sampling or chordocentesis should have been done, because SS, all of you know, we have heard, the hemoglobinopathies, they are, they take the toll of your life, everything, not only finances, but emotions also. Okay, so sickle cell anemia, all of you know that it is a disease of RBCs, sickle cell. They are very fragile and, break easily. They are, they are very sensitive to hypoxia. So how do you counsel this patient? What all things they should avoid?
Mainly the hypoxia, dehydration, and all these things have to be avoided. Hence, antenatal care forms a challenging part here. She has to visit a doctor so that she needs to to be told about like what all to avoid so that she doesn't go for a hypoxia or a dehydration condition, like going for an high altitudes or going in a crowded areas and visits. Yes, closed areas.
Right.
And the visits of antenatal visits have to be very frequently. Let it be like next another weeks like that than the normal ANCs.
Right. So what are the, okay, so that is all about sickle cell crisis. And there is, recently there has been a recommendation of using low dose heparin. Okay,
Heparin. Low molecular weight heparin.
Low molecular weight heparin, because of this, all this sequestration, as well as, maybe the chances for microthrombi, that is how, you can, if you use this as prophylaxis. Some people use either what is that, low molecular weight heparin, or even Pandoparinax, that is fluxum. These are the drugs which they have been, hematologists, they advise you to use throughout pregnancy. Okay, so I think last question we will have, what is the recommendation of Government of India for Anemia Mukta Bharat? I think we will try to skip this ITP, though all of you feel it is very interesting. What is the recommendation for Government of India? By Government of India, for Anemia Mukta Bharat, that I have already asked you.
So Anemia Mukta Bharat is a strategy which was started in 2018 by Government of India to reduce anemia in women, children, and adolescents. It's a part of Poshan Abhiyan, that is Prime Minister Nutrition Overarch Scheme of Holistic Nutrition.
Right.
It has got a strategy called as 6:6:6. What is the 6:6:6 is 6 beneficiaries, 6 interventions, and 6 mechanisms.
Right.
Here they take care of 6 beneficiaries, ma'am. That is age group from 6 weeks to 5 years is the first beneficiary. From 5 years to 10 years is the second beneficiary. From 10 to 19 years, then reproductive age group, then pregnant ladies. So this is the beneficiary group, that is 6 beneficiaries. And 6 interventions, like what are the interventions is they give a prophylactic iron with folic acid tablet. First intervention is every lady should receive this beneficiary should receive prophylactic iron with folic acid supplementation. And this supplementation have got color coding, ma'am. They for 6 weeks to, 5 years kid, the suspension is given, then pink color tablet is given for 5 to 10 years, then blue color. This color coding is there. The second intervention is periodic deworming is done. And this deworming in Government of India has given 2 days, 5th February and in the month of August, where the deworming is done all over world from 1 year to 19-year kids. And the next intervention will be intensifying this behavioral and communication campaigns. They give campaigns are done. And testing. The 4th intervention will be testing for treatment of anemia. Like digital hemoglobinometers are given by Government of India to the sub-centers level and the field workers. And in PHCs, they have given a semi-automatic analyzers are given. And testing and treatment of anemia is done at the lower level. Then mandatory provision of fortified iron and like rice is fortified and grains are fortified in this schools, and then Anganwadi where they give food, they are mandatorily fortified with iron and folic acid. And next, the last one is addressing the non-nutritional cause of anemia. So this is the next 6 ones. First 6 one will be beneficiaries, next 6 one will be intervention, and the last 6 will be government mechanisms, madam. It is not for us doctors, it is interministerial this thing. So this is how Anemia Mukt Bharat is working, and these are the programs they run.
Right. So, in fact, all of us have to remember this. This is a very, very effective strategy, what you have discussed, and already, how you have to give, you have to make sure that the iron reaches each and every pregnant woman also. So, how the basic unit of our healthcare system, the Anganwadi and Asha Sevikas go home to home and reach every pregnant woman. That also we have to make sure, because, over the years, we have this, Anemia Mukt Bharat, the things are going on. Government is giving the supplementations, people are distributing, and still, it is not getting effectively controlled. So definitely we have to think beyond all this and come up with a solid solution. So with this, I think I've got lots and lots of interesting cases, thrombocytopenia, thrombophilia, but then because of lack of time, I've shared the presentation already to all of you. Please go through and make use of it. I thank all the, I think I take a last word. I did not see actually Uma madam. Is she here?
Hello, yes, madam. I'm
Madam,
here.
so sorry, the discussion was going on and on,
Yes,
but
yes.
I
I was on the discussion time.
Okay, okay.
I was here.
Madam, I
And
request,
all the best for
please
you,
conclude.
madam.
Yes.
Thank you. And it was very nice. And we came to know each and everything from Megha madam and Rajshree Paladi madam. And it was the nicely they have explained. And we came to know many things from them. And first, always we have to, what you have said, every trimester we have to check for the hemoglobin and how to manage even injectable, how to give according to the formula, Ansoni formula, how to give. And if after giving also, if it is not improving, then we have to go for electrophoresis. Usually we are not doing it here in our place, but then now we have to start doing it, madam.
Okay, okay. So thank you so much, madam, for your, very precious comments that has added value to our discussion. And definitely we would like to connect with you all in future also. So thank you so much, all my learned panelists. Again,
Madam, I will invite you for our Bidar Obstetric Society's zonal conference. It is on August 2nd and 3rd.
Okay, madam. Thank you so much. That is definitely a privilege for me. I would try to make it, madam. Thank you.
Thank you. Thank you very much, madam.
Thank you so much. And yes, I just take this opportunity to humbly seek all of your blessings and votes and support for my candidature. Kasoga has been very close to my heart, and all of you know that I have been working for FOXI, ICOG, and all these emergency obstetrics committees over now almost 25 years. And I myself being, apart from these national, international awards and all my national posts, and more than 35 publications and 400 plus talks, I tell myself, or I consider myself, a very hardcore and high risk obstetric practitioner. I have individually delivered more than 20,000 women and more than 8,000 major surgeries. So I request your support. I am one amongst you, and I'm your representative. Thank you so much.
Thank you, ma'am, for having all of us here, ma'am. We are definitely with you, ma'am. It's a privilege to have you. Thank you so much.
Thank you so much. So I thank Dr. Megha for convening this program, and I thank Dr. Shanta Durge and Dr. Kritika for all the hard work coordinating with all of you. Thank you so much, Dr. MG Hiramat sir, Dr. Durgadas Asrana, and of course Dr. Shobha Gudi, Dr. Vidya Tobi, and Dr. Kasturi Donimath, all the office bearers of Kasoga, and all the president secretaries. I have already personally thanked you. So thank you so much once again. Please do vote for me. Thank you so much.
Thank you all. Thank you all.
Thank you, ma'am. Thank you.
Thank you, Sneha madam, for including in this. Thanks.
Dr. Kritika, yes.
I would like to present the vote of thanks. Now we have come to an end of the academic feast. First,
thank you, Kritika. You have done well.
Thank you, ma'am. Thank you so much. So first and foremost, I would like to express my sincere gratitude to our guests of honor, Dr. M.G. Hiremat sir, Dr. Kiran Kurtkoti sir, Dr. Durgadas sir, and Dr. Seetha ma'am, who despite their busy schedules have found time to grace this occasion. And I also express my heartfelt thanks to our special guests, Dr. Vidya Tobi ma'am and Dr. Kasturi Donimath ma'am. Your presence and contributions have enriched the discussions and made this event a collaborative success. A heartfelt thanks to our distinguished speakers, Dr. Rajshree Paladi ma'am and Dr. Megha Kamlapurkar ma'am. Your presentations and discussions have been incredibly informative and engaging, offering us with new perspectives and ideas. A special thanks to the chairpersons and expert. I'm extremely thankful for giving your valuable time and for sharing your expertise and knowledge. A special thanks to Dr. Sneha Bhuyar ma'am. Your generous support and guidance has been instrumental in making this event possible and successful. I sincerely thank all the distinguished panelists present here for accepting the invitation at a short notice and enlightening us with your knowledge. In conclusion, I thank you all once again for your invaluable cooperation and participation. Have a great evening. Thank you so much, everyone.
Thank you, Dr. Kritika. Special thanks to you.
Thank you, ma'am. Thank you so much.
Thank you all. Yeah, thank you.